stand here and look here.
Yep.
So the cameras, seriously, I want you to stand right here and just like, just get a feel for it because
Okay.
it's really easy. Okay, good.
I'll just bring it up when I go.
Hey, Maeve. I want Maeve to do something with you, Cody. Yeah. What? She's gonna do a little story. No, you're just stay hand.
Stay put, huh?
Yeah.
Sorry.
So I'm going to introduce you. My thing is to introduce Jan. I'm introducing Jan, and then after Jan, I'm introducing Good. Yeah. Let me just see if this.
Yeah, Megan too.
First Tim and then Megan. Okay. Yeah. Just cue me if I look like a deer in headlights. We're gonna be great.
Good morning. We are ready to start. If everyone can draw their attention over here to the podium. My name is Katie Horvath. I am an advocate and a volunteer for Less Cancer, and I also am a cancer survivor. When I was going through my diagnosis and treatment, I was raising an elementary school daughter on my own, and not only was it a very scary time, but let's face it, cancer treatment is brutal. My oncologist used to say, there are 3 ways we deal with cancer. We either cut it out of you, we poison it with chemo, or we nuke it with radiation. And it's very brutal and very difficult, despite the amazing advances we have toward the cures for different kinds of cancer. So I'm not somebody to sit back and believe that whether or not I have cancer is completely up to fate. I take action. And I immediately started to research what could I do in my own life to prevent myself from ever getting a recurrence, prevent my daughter from ever having to go through cancer treatment, my family, and my community. I learned lots of different things that you can do on your own, in our own homes, in our communities. Behavioral changes, diet, exercise, what we choose to clean our homes with, what we put on our lawns, and even what we drink in our water. For years, clean, safe drinking water for everybody has been a passion of mine. I've served for 6 years on the board of an organization called Flow for Love of Water, promoting clean, safe drinking water in the Great Lakes region. But most, I'm proud of turning my cancer lemons into lemonade by being on a team to open a cancer center for a regional healthcare center, a regional healthcare system. I was in charge of ancillary services, which at times felt like everything but the healthcare itself, but importantly, it included programs about cancer prevention. And it was in the middle of that work I was doing when I met Bill Cousins, founder of Less Cancer. Out of the blue, I received a phone call. Hi, this is Bill Cousins. I heard you're doing great things in cancer prevention. Can I help? And that's exactly the spirit of Bill Cousins. Helping a hand, running around the country, traveling here and there to educate people on cancer prevention, to step in and speak and do what he can to make sure that our entire country, every community, is aware and educated on prevention and has programs toward prevention. You know, really, Bill came to it out of cancer in his own family as well. When he saw family members dealing with cancer, he said, well, what can we do to prevent this? At the time, everyone said, you can't prevent cancer. We just need to cure it. But Bill was relentless and refused to take no for an answer. He said, there's got to be something we can do. And here we are today in 2020, and cancer prevention is not only a national topic, thanks in large part to Bill Cousins, but it's also considered to be the best way to deal with cancer altogether, still, at this day and age. So it is my great honor to introduce the president and the founder of Less Cancer, Mr. Bill Cousins.
Thank you very much. I appreciate that. Can you back up one second? Here, Katie. Thanks so much. I appreciate it. Thank you for everything you do. Thanks again, Katie. That was super nice, and appreciate all the good work you do. I want to welcome everybody here today, students, policymakers, educators, healthcare providers, public health professionals. Thanks for joining us today in this studio audience here on Capitol Hill and globally on Facebook through our Facebook Live channels. So thank you for being here. The official name of this organization is Next Generation Choices Foundation. And when we started this workshop 9 years ago, they were like, oh, no, we don't really do students for this kind of thing. And I was like, well, students are what we're about. We are about kids. We are about the next generation. We are about empowering the next generation. Doesn't really matter what I say because I'm not one of these scientists or one of these physicians. I'm just a guy that wanted less cancer. But I also wanted it for my daughter who's in the audience, my son who will be here later, because I didn't want them to have the suffering associated with cancer either as a patient or a survivor. And there are many things that we can do to reduce risk, and that's the basis of our work. We're super fortunate to have the University of Virginia School of Medicine, continuing medical education, be part of this. They are the ones that vet this continuing medical education, so you know that you're getting the best content ever. American University is helping us with our public health continuing medical education. Super grateful to them. And I'm grateful to our board members. We have an extraordinary group of board members who you will meet throughout the course of the day that are great advocates for less cancer. And they've been so helpful in growing this organization to something unimaginable. As some of you might know, some of you don't, we are not a big cancer organization. We don't have the tobacco companies sponsoring our smoking cessation programs. We don't have the chemical companies helping us to manage lawns. We are funded and operated and propelled at the grassroots level. It's people just like you, people who are in our live audience today around the globe that have advanced less cancer. They are the people like me, like you, like all of us that want to prevent the suffering that comes with cancer. They want to prevent it altogether. They want you to have a life to live. Cancer should never be an expected stage of life, ever. And your life is never the same once you address cancer. Our work is solely devoted to preventing that diagnosis. And none of this would happen if we didn't have the extraordinary men and women and young men and women here today, and I'm so grateful for all of you being here. I want to introduce Jan Balmer, our chairwoman, who is our third chairwoman, our third chairman. The first was Dr. Sherman, Donna Eco. Where is Donna Eco? There. Was our chairman last year, and this year it's Jan Balmer. Jan, can you come on up and say hi?
Sure.
Thanks.
Absolutely.
I'm going to turn it over to Jan. Thank you. Can you do this?
Sure, that's fine. Thank you so much. Thank you so much. This is a really important event. It is an important event because it is not traditional. We are really reaching out to the public, to students, to legislators and other people, and we are really a volunteer-driven organization. So the role of education is incredibly important. If you don't know what you should do to prevent cancer, then you can't really successfully do it. We need to make sure that everybody that's engaged from the public and the healthcare providers to be able to know what the ways are that you can prevent cancer. And so our role in the Office of Continuing Medical Education, along with our School of Nursing continuing education program, really spend time looking at the evidence and vetting all of the information to make sure that we're giving you the best science and the best research and the best approaches to preventing cancer as much as possible. We're pleased to say that today's program is accredited for both CME credit, continuing medical education credit, and continuing nursing education credit. There is a form for the people that are here in the studio audience to fill out. It gives you the instructions to do it online. For people that are watching us streaming, you can go to www.cme Village and fill out your information that way. We are thrilled to be here this morning. We're happy to be involved, and we really look forward to today's program.
How lucky are we to have Jan, right? She's a rock star, and we are so lucky. But I am fortunate to introduce our Less Cancer Leadership speaker. We have a couple this year. The first one is Tim Pulliam. And before I ask Tim to come up, he is our lead guy in Traverse City, Michigan that does the Less Cancer Bike Ride. It's this extraordinary ride that originally started from Detroit to northern Michigan. Now it is fully in that Traverse City area around the Leelanau Peninsula. Last year, this is like a Tim Pulliam call. He's like, hi, I need you to join my bike ride. Well, I can't, I'm really busy that Saturday. We'll be at your house at 3 a.m. and pick you up. So he like shows up with a truck and kidnappers of some sort and picks up these guys and women, and these are amazing athletes. And every year they ride for less cancer. And because of their extraordinary efforts, we are so lucky to have them working for us. We raise enough money to do events like this. And we're super blessed to have people like Tim in the less cancer world and in our lives. And Tim, can you come up and say hi to everybody and say a couple words? Thanks so much for everything.
Yeah, sounds great. Hi, well, first off, thanks everybody for being here. And yeah, Less Cancer is really an organization that is near and dear to my heart. You know, I lost my father when I was 8 to mesothelioma, definitely a preventable form of cancer. And so at my company, when we do industrial sustainability and efficiency, it was easy to draw a connection between what we do and, you know, a reduction in potential environmental contaminants, but it's harder to put a personal touch on it. It's harder to see an impact that you actually can have through that work on an actual human being. And Less Cancer and our participation in the bike ride and the funds we raise, and then what they go to promote policies and the education necessary to help us avoid some of these contaminants and hazards, it's really a special thing. It really means a lot to us. And it also allows us to create and have the framework at our company that allows our staff and our employees and our team and now our vendors and even our customers the framework and infrastructure necessary to live a healthy and active lifestyle, to be aware of what those hazards are and reduce them as much as possible, and to really live as clean and a healthy and enjoyable life as we all can together, or promoting great organizations like Less Cancer. So that's what I have to say about it, and I really thank everybody for being here. Thank you.
We'll take a quick picture. Thank you very much. We're super grateful for all you do. Missy, can you just take a quick picture of us here? Or we can slide down. We'll slide down quickly. Just, sure.
Thank you.
Thank you very much, Tim. So that was fun. We have to do things like pictures. And because we are sharing messages and stories, and a lot of times we send stories out and messages with pictures. So the next person who is an extraordinary Less Cancer leader is Megan Catalfmo. Who here is with her? Who here is with her? Okay. So you are literally one of countless kids that have come with Mrs. Catalfmo from the Highland School in Warrenton, Virginia. And every year, Mrs. Catalfmo seizes the day to discuss some of these issues with her students and get them involved and engaged. She has been critical in building this workshop. She's been critical because, well, first of all, I have to say about Highland School, you're extraordinary students. This is part of your conversation. This is part of your culture. And we love all the students here today, but Highland School has really been one that has been part of growing this programming, and we feel especially fortunate. Megan, can you come up here for a few minutes and say a couple words? This is Megan Catalfmo, everybody. Please come up.
Sorry. This is good. All right, great. Well, thank you so much, Bill, Andrea, the Less Cancer Board. I'm honored and deeply humbled to be here today representing Highland School with my colleague, Leslie Ziegler. She's our AP Bio teacher. She has also had a career as a nurse with high-risk pregnancies and in a public county hospital caring for underserved populations. So we have a deep affinity and appreciation for the nursing students who are here in the audience and watching, and commend you for choosing such an admirable career. We are here with our AP Bio students and our Leadership Studies students, and we're so grateful to be included in this conversation and invited to participate, to share space and time with all of the experts, leaders, change makers from so many sectors of public and private life. In leadership class, we like to say that Bill is an exemplar of inspiring a shared vision, which is enlisting others to promote a collective goal by connecting that vision to our personal values for each individual. This National Cancer Prevention Workshop is an incredible opportunity for our students to witness effective collaboration in action on Capitol Hill, no less, and to interact with so many of you who model servant leadership. First, I have to put my teacher hat on, though. Today, our students have an in-class assignment that I just want to remind them about. So Ms. Ziegler and I gave them 3 expectations for today. The first one was to pay attention, take notes, soak it up, let's bring it home, let's share the privilege that we have today with those that aren't privileged to be here with us today. The second is, if you need a snack, and I know you will, just don't crinkle the wrapper while others are talking. And then the third, and this is where we need your help, their assignment is to shake the hand of an adult, to introduce themselves, to make a connection, to make great eye contact, and to start a conversation as a building place for leadership. To the 18 and older crowd, we hope you might help us with this. So if you see a tentative student or a pair of them, if you'll just extend your hand first, that would be great. You're gonna love meeting them. They're amazing human beings. This is the best part of my life and my job. They're incredible to work with. But I want to talk a little bit more about collaboration, specifically intergenerational collaboration. So I'm going to be nosy, and I'm going to ask you how old you are. So if you're in high school, will you raise your hand? Good, they're paying attention. That's so fantastic. If you graduated from high school in the last 5 years, you get TikTok references, renegade references, things that words I shouldn't even be saying. Okay, 10 years? 15? 20? 25, maybe a little bit longer. So this is what's so great. The thing that I'm interested in is engaging students in citizen action and community action and us working together to solve big problems. 5 years ago, Mr. Cousins extended an invitation to our school to this event, and we arrived to discover that the connection was not just around a shared concern for a public health issue, it was personal. Board member Tom Sherman had his children at Highland for a few years, but one of his dearest friends and one of our best colleagues, Anna Bowman, was a shared connection. She was beloved. She was our librarian, our middle school guidance counselor. She was our service club advisor, and everyone loved her. She was vibrant, funny, and most of all, she believed in her students. When she passed away from cancer, much too young, we were devastated. I'll never forget the first time I visited Anna's service club meeting. It was a room full of loud, sweaty, rambunctious middle schoolers, bubbling with excitement, making grandiose plans for their signature project. Everybody wanted to do every job. There were a million jobs to be done, and everybody had their hand up. And what cause, might you ask, fired them up? Was it contaminants in drinking water? No. Was it multi-billion-dollar companies spewing toxins into our environment? No. What got that fervor of activism was feral cats. Feral cats. Who knew? Who knew? I don't know. MC, were you involved in the Feral Cat Project? Yes, she was. So presiding over this lively caucus was not Anna Bowman herself, but it was one of her students, a 6th grader surrounded by other co-captains. This was a student-led project. It was student-driven, and it was student energy that made it happen. Anna knew the secret formula for engaging students: invite, inspire, and empower. She invited them. She invited them to the conversation. She invited their personalities, their energy, their passions, their crazy ideas. Everything was fair game and deserved to be heard. She inspired students through education and awareness. She didn't just tell them about the feral cat problem. She took them out to the neighborhoods to trap them. She brought in experts from the SPCA, and students came up with their own reasons for why they were devoted to the cause. And lastly, Anna empowered students to take action in a myriad of ways: bake sales and research, assembly presentations, writing letters to local officials. Another brilliant colleague of mine and our social justice teacher, Margie Kuzminski, calls these on-ramps. They're access points to the highway of community activism, to community-led systemic change. And put simply, Anna created opportunities for her students to make a difference. Those students who first learned those skills through their Feral Cat project, went on to apply them to future causes. MC Truding with Less Cancer Support started the Tan Less Shine More campaign. 3 of my students concerned with disparities related to housing access started the Dignity Project to conduct outreach to families living in low-rent motels. And many others are creating their own on-ramps to make change in their communities. It's now our duty to employ this secret formula, and I'm grateful to have Anna's example, but I wish she were here to continue to collaborate with. It would be so much more fun with Anna. So it is personal for me, for Tom, for Highland, for Bill, for Less Cancer, for each of us in this room, and it has to be. And thankfully, because of this workshop, which masterfully employs the secret formula of invite, inspire, and empower, we have the opportunity to learn, to create, to celebrate, and to utilize on-ramps so that we can get to a place where cancer is prevented and eradicated. Each of us, whether under or over 18 years of old, can be the Rob Balotts and the Dr. Mona Hanna-Atishas, the researchers, the public health advocates, the lawmakers, filmmakers, journalists, and nonprofit directors of our own generations to inspire, invite, and empower others. So thank you again for including Highland School, and we are so grateful to be here. Thank you, Bill.
So nice. I appreciate it. Can we take a quick picture? Let's take a quick picture. This is a rock star here. Thank you very much. No, we're good. Thanks. Yep, she is here. Okay. So our next speaker is the Eileen O'Brien Graves Speaker Award. And I'm going to read because I don't have this kind of memory to get all the details exact. But it's Dr. Claudine Isaac. She's a co-director of the Breast Cancer Program and medical director of the Jess and Mildred Fisher Center for Hereditary Cancer and Clinical Genomics Research at the Lombardi Comprehensive Cancer Care Center, Georgetown University Hospital. Dr. Isaac's extensive research covers all aspects of breast cancer, including cancer risk and novel prevention, screening, and medical management strategies for women at high risk. Toward the end, she has served as a principal investigator or co-investigator for numerous clinical trials and grants exploring potential new treatments for early stage and metastatic breast cancer. Dr. Isaacs was also the PI for the Cancer Genetics Network site and for the prostate, lung, colorectal, and ovarian cancer screening trial. Anyway, I want to turn this over to you, Doctor. Would you like to be at the podium or here? Thank you very much for being here. Can we welcome Dr.?
Thank you very much. I'm really deeply honored to be the recipient of the Eileen O'Brien Grafe Award. And while I did not have the privilege of knowing Eileen personally, it's really very clear to me from reading and viewing all of the tributes to her that she was really an incredible woman who left an indelible mark and legacy on a number of you here today. I'm also a mother, and seeing all of you high school students here today. My kids are a little bit older than you, but seeing all of you here today, and those of you who are 5 years up and more, what you do and what you are going to bring to our world tomorrow is really important. So it's really impressive to see you here today for an activity like this. Now, I'm a breast cancer medical oncologist who has worked in this field, dare I say, mercifully didn't ask us our exact age, but over 2.5 decades. And I think most of you in this room know the devastation that a breast cancer diagnosis can cause. It is the leading cause of cancer amongst North American women, and is the second leading cause of cancer-related deaths in this country. And as a medical community, we really have made tremendous strides in the treatment of breast cancer and its early detection. As a result, breast cancer-related mortality has declined steadily over the last several decades. And with our current advances that are really happening at a dizzying pace, the outlook remains better and better for women diagnosed with this disease in this country today. So one thing that I want to leave you with, and I know that's not the topic of prevention, but I do want to leave you with a message of hope, or start this off with a message of hope, is that for the vast majority of North American women who are diagnosed with breast cancer today, the vast majority of them will survive and thrive with having had this diagnosis. Nonetheless, unfortunately, some women will succumb, and many of the women who are diagnosed with breast cancer will obviously have to suffer the side effects and toxicities of the treatments that we prescribe. And I think it's probably abundantly clear to all of you in this room and to most of us in this field that the best way to prevent a cancer-related death would be never to have anyone diagnosed with this disease. So this has been a very active area of research in the medical community, and I want to share with you some of what we know about breast cancer-related risk factors and some of what we can do to prevent this disease. Now, we know that there are a number of different breast cancer-related risk factors, but breast cancer isn't one of those diseases where there is a single dominant risk factor. And as an example, if we think about lung cancer and smoking, there's a very, very clear link. And in that situation, smoking is at least theoretically a modifiable risk factor, and you're going to hear more about it's not so easy to modify. The best thing I can say to all of you who are of the age where you haven't started yet, don't start, okay? Because it's not so easy to quit once you've started smoking or been exposed to tobacco-related products. But in the case of breast cancer, we do know that there are some risk factors that can be modified, but some that can't. For instance, family history is a well-recognized risk factor for breast cancer. And for women who have a family member, a first-degree relative with breast cancer, they have up to a twofold increased risk of developing this disease. And that risk is increased further if their first-degree relative is diagnosed at a younger age. And for a small subset, about 10% of all women with breast cancer, they develop it because they have inherited a predisposition to this disease. And when we say somebody has a hereditary predisposition or inherited a predisposition, what we mean is that they have inherited a single mutation or a change in a single gene that significantly increases their risk of developing breast cancer. And the one that I think we hear a lot about in the media, and that's the most common one, are mutations in genes like BRCA1 or BRCA2. BRCA1 is a gene that Angelina Jolie had, and that she, I think, in such an important way, shared with us something about her that was so impactful on all of us. Now, unfortunately, at least in 2020, there's not a lot we can do about what we inherit, the genes that we inherit from our parents. But knowing that information can be incredibly impactful, because we now have good data that women who inherit mutations in BRCA1 and BRCA2 can do something to minimize their cancer risk. What studies have shown is that more intensive cancer screening or preventative surgeries can significantly reduce the risk of a mutation carrier developing that cancer. Obviously, what we would like to be doing is something far less aggressive and intrusive than recommending surgery to people who inherit mutations in those genes. And there's a lot of active research, a lot of federally funded and foundation-funded research that is going into trying to elucidate better means of preventing cancer in people who have an inherited predisposition to this disease. I also want to parenthetically note that when we talk a lot about women, men also can inherit mutations in BRCA1 and BRCA2. They also have increased risks for developing some cancers if they have a mutation in one of those genes, and they can pass it on to their children. So for those of you, again, and I tell that to our medical residents, our fellows, my colleagues, to remember what you were taught in high school biology about inheritance. That's true for a lot of diseases in medicine, and it's an important thing. What you are learning today is a foundation in AP Bio and below, is a foundation for a lot of what we do in medicine. The other thing about genetics is that it impacts not only the individual, right? It impacts their whole family. And so there has been a lot of research, and we and others have been involved in research, that once somebody finds out that they have a mutation in one of these genes, it's critically important that we figure out how they share that information with other family members so that they can be empowered to do something about that as well. And the other notion of this is while we live in Washington, D.C., and people have access to academic medical centers and big hospitals where you have access to services like genetic counseling and testing, that's not true for large parts of this country. So again, there has been a lot of research that has been ongoing to figure out how we avail people of some of these services who aren't in parts of the country where they have easy access to this. Now, there are a host of other risk factors associated with breast cancer, and some of these can be modified, and these fall under categories like lifestyle factors or some reproductive factors. So alcohol is a recognized risk factor, weight is a risk factor for breast cancer, exercise is important, breastfeeding is important. I just want to touch on some of those very quickly. We know that even one drink a day can modestly increase the risk of breast cancer, but more excessive drinking can increase the risk more significantly. So it's important for many health-related things that we should be thinking about to recommend moderate alcohol intake. Weight, I think we hear about all the time, and really it is going to surpass smoking and other environmental exposures as the leading cause of cancer in this country. Obesity is a risk factor for many, many, many diseases, cancer included and breast cancer included. We know that women who are obese have a significantly increased risk of developing breast cancer in their postmenopausal years. We know that even more normal weight or overweight women who have a higher percent body fat also have an increased risk for developing breast cancer. And again, breast cancer is just one of the many diseases that is associated that has that relationship between obesity and increased risk. So maintaining healthy body weight is something that we really need to focus on, and that's a very multifactorial issue that I think many of you in this room are much more involved in and know much more about. Exercise is good for everything, too. It's also good to reduce the risk of breast cancer, so we know that it's important for women to exercise, and that helps to reduce their risk. And one of the other factors that we know about and that we talk about is that breastfeeding is protective against breast cancer. So we know that women who breastfeed for at least 3 to 6 months after each pregnancy reduce their risk of developing breast cancer. So it's a very important, I think, public health message that breastfeeding is not only important for the baby, it's also important for the mother's health. So despite everything that we know about these breast cancer risk factors, and I promise you I haven't gone through all of them by any means, it only accounts for about 60% of the known breast cancer risk factors. So what we understand is that there's a lot that we don't yet understand. And that those 40% or so of women who develop breast cancer who don't have any of these recognized risk factors, it's probably because of some complex interplay between environmental exposures and our own makeup, how we metabolize some of those things that we're exposed to. And this combination of events probably have some interplay on how people develop breast cancer. And I don't want to leave you with the notion that the medical community and the scientific community have not tried to decipher those. It's really, really hard to prove causation. Many risk factors are interrelated, and it's very hard to tease them out. But I know some of the work that this foundation does and this supports is trying to further elucidate some of those underpinnings of cancer. We have also made strides in how we can prevent cancer in women who are at increased risk for a variety of reasons. There have been several very large federally funded studies and some studies funded by others that have shown that if we identify women who are at increased risk, there are medications that we can give to diminish their risk for developing breast cancer. And those are very well characterized or very well carried out randomized clinical trials that have shown that. So what do I want to leave you with? I think I want to leave you with a concept and something that's very important just for anyone who is diagnosed with breast cancer. The prognosis is really excellent in 2020. It's complicated. There are also some people, due to socioeconomic factors and racial factors, that have a worse prognosis, and that's something that we're really trying to better understand. But we have made tremendous strides in the treatment of breast cancer, such that we now can tell most women who are diagnosed that they will survive their disease. We're also learning how to pull back on some of our toxic treatments and to be better able to personalize or individualize the care that we give so that we're not exposing everyone to all of the toxicities of the various treatments that we have at hand. But obviously what we want to do is prevent women from ever developing this disease. And a thing that I think that all of you can know, it's important to be empowered, to know about your family history. There is a family history of a disease, to talk to your healthcare provider about it. Not everything is genetic. In fact, most things aren't. So I don't want people to leave here thinking that they likely have a genetic predisposition. They don't. That is uncommon, but it is important to know about it and talk to your healthcare provider about it. There are things that we can do to minimize breast cancer risk. So maintaining healthy body weight is critically important for so many things, as we talked about. Exercise, keeping alcohol intake to moderate levels, and encouraging breastfeeding, not only for the baby's health, but also for the mother's health. And then clearly, the importance of further research to better understand the underpinnings of breast cancer so we can further minimize risk. So I want to thank you again for this award. I'm very deeply grateful, and I want to thank you for your attention.
That was amazing, super amazing. Thank you so much. I just want to say one thing. This is such an interesting conversation to have, and you are heroic in your work, and we are so grateful for you. I myself went through something where I had to go through genetic testing, and I learned it might not be in your genes, but it might be in your family. And so we discover, for instance, in my family, it's not in my genes, but we have lots of pancreatic cancer. So they they watch me for that. And I learned about that here, and I learned about what you were saying right here at our own workshops that we've developed. So the information that you provided today is so empowering for so many of us. And you really, we're really grateful to you. I'm just wondering, does anybody have a quick question for Doctor? Anybody out there? And if it's okay, what I'd like to do is get the board members up here. Can we take a picture with you? That would be great. Board members, please join me over here. That would be great. No, thank you. Let me give you something here, too. I really appreciate your help. Let's go here. It was amazing. Donna was our chairman. Do you know Jan Ballmer, too?
Hi.
So our next, I'm going to turn this on. So our next speaker award is a Ronald B. Herberman Speaker Award, and that speaker is going to be joining us by video. First off, I wanted to mention something about Dr. Herberman. He was really a founding board member of Less Cancer. He was a founding executive director for the University of Pittsburgh Hillman Cancer Center. He was with the National Cancer Institute. He was an amazing man. He was the one that, in our early conversations, we really talked about this idea of preventing cancer and the critical importance of having evidence-based science be behind anything. You should know I am not a scientist. I'm not an advanced degree person. I'm not like any of our experts in the room today. I am just a person that wanted less cancer. And so while that's fine, the intention never overrides intelligence. And so the fact that we have all these extraordinary people today is great. And we do that in the spirit of Dr. Herberman. So I want to tell you, Rob Kissel is the producer for the movie Dark Waters. Has anybody in here seen the movie Dark Waters? It's based on the story of our board member, Rob Bilott. And Rob's book, Exposure, is over there. And so I just wanted to tell you a little bit about, I'm trying to get in here over, how are we doing down there, David? We're ready to go. Whenever you're ready. Okay. So Robert Kissel is the Executive Vice President Productions at Participant Media, where he co-manages the development and production of the company's narrative film slate. Since joining Participant in 2013, Kissel has been an integral part in the production of the company's most commercially successful films to date. And he is the producer of this movie. And are we set up technically to start this? right now? Okay, we're going to start. I appreciate your patience in this. Thank you.
Hey, it's Robert Kessel coming to you from Participant Media in Los Angeles. Thank you so much to Less Cancer and the Next Generation Choices Foundation for this award, and to everyone in the room today participating in this important workshop. I wish I could be there with you. The journey of Dark Waters begins and ends with Rob Bilott, without whose uncompromising and unparalleled passion and commitment I would not be accepting this award. He truly is a modern-day hero. The making of Dark Waters has been an enlightening journey for all of us at Participant. Mark Ruffalo has said that often the culture calls a movie into being, and Dark Waters is no exception. It's been incredible to see how this film has been received, especially by those who have been affected by these forever chemicals. I'm so proud to be able to work for a company like Participant that makes movies that create awareness and educates people to issues that for too long have gone unnoticed. This has been an educational journey for all of us, and we couldn't be more grateful to have had so much support from organizations on the front lines of this issue. We stand with those fighting toxic pollution and illnesses that come with it. Thank you again.
So that was great. If you haven't seen the movie, please see the movie. And we're going to watch the trailer now.
Almost heaven, West Virginia, Blue Ridge Mountains.
Hi, Grammars.
What are you doing here?
Your grandma tells me her grandson's some fancy environment lawyer down in Cincinnati.
I am a corporate defense attorney.
So?
I defend chemical companies.
Well, now you can defend me.
How many did you lose?
190.
190 cows.
You tell me nothing's wrong here.
It's a small matter for a family friend. Help a guy who needs it.
The farmer or you? That's chemicals, I'm telling you.
I'm seeing documents I don't understand. They're hiding something. That chemical. What if you drank it?
Drank it? It's like saying, what if I swallowed a tire?
What if whatever's killing those cows is in the drinking water?
At DuPont, better living through chemistry. It's our DNA.
You need to tell me what in the hell's going on.
DuPont is knowingly poisoning 70,000 local residents for the last 40 years. You knew, still you did nothing.
You want to flush your career down the toilet for some cowhand?
You want to take everything that you know and turn it against an iconic American company, like an informant. Isn't that right? Isn't that right? Isn't that right?
Yes. They have all the money, all the firepower, and they'll use it. I know. I was one of them. Our government is captive to DuPont. They're trying to force you to make me stop.
He was willing to risk his job, his family, for a stranger who needed his help.
The system is rigged. They want us to think it'll protect us. We protect us. We do.
So Rob Bilott is our hero, and such a critical board member for us. He unfortunately is in the UK today, but his work has been so important on several fronts, and we feel very, very lucky to have him be part of us. He's a very humble man. He has helped a lot of people He's devoted his life to helping others in this way, and we're very grateful to him. If any of the young people have a question about any of these issues, or even in the book, don't let the information scare you, but if you have any questions, feel free to ask your teachers or have them reach out to me. And it shouldn't be scary now because it's being addressed. And I want you to know that it is being addressed. It doesn't mean we're out of it, but we're working on it, and Less Cancer is working on it. And if any of you feel like you need to reach out on any specifics, please do. Because we don't want you afraid, we want you engaged. And we want you learning about some of these issues that are so important to have a healthy life and a healthy environment. So we have some speakers that are moving around, but we are going to then go to the Elsie Hillman Speaker Award, or is that? We're going to go, I'm sorry, where's Janie Heath? Please come up here. Janie Heath is a board member here that has done extraordinary things. She's a dean of nursing at the University of Kentucky. You never want to hold a cigarette near her, anybody out here, any young people. She's got a pistol. They have, but she is a leading expert in this area. She says she's not, I say she is, but the world is different because of Janie Heath. And I just want to turn this over so you can talk about your conversation coming up.
Okay, so I'm going to take this microphone. I'm going to bust it up a little bit because that's the way we do it in Kentucky, because we are from the Big Blue Nursing Nation, and we are after our national championship. Love you guys, University of Virginia, but we're going for it. University of Kentucky, Wildcats, we're on it. So I just want to tell you a little bit about my connection with Less Cancer and how I met Bill Cousins. And it was when I was actually the Associate Dean of Academics at the University of Virginia, when my dean, and you all probably still remember her, Dr. Dory Fontaine, was at a football game with Bill. And she heard Bill talking about his organization. And she just perked up. She goes, "Do you know about my researcher, Janie Heath, and her work with tobacco control?" And Bill said, "No, I don't. I want to meet her." And it has just been the most wonderful journey since then. So it's going on year 10, actually. And we started this partnership. And just as Dr. Michael Swanberg brought all of you from the University of Virginia, that's what we started doing 10 years ago. We'd load up in the bus and come up here and have so much fun. So I'm so glad to see that that tradition continues. I've been passionate about tobacco control all of my nursing career. So I'm going on 43 years. My mother died from brain cancer when I was 10. My father died from metastatic lung cancer when I was 30. My mom was a one-day-a-pack smoker. My dad was a two-day-a-pack smoker. So I go to the University of Virginia, and I'm out to just save the world and just do all kinds of great things, because you know the belly of the beast is right there in Richmond, Virginia. So I had lots of great experience, lots of great impact and making a difference here in the Commonwealth of Virginia. And now I'm at the University of Kentucky, where we got some problems with tobacco in Kentucky. We have among the highest smoking rates in Kentucky and the highest lung cancer rates in Kentucky. And I never thought that I would be selected to be the Dean of Nursing at the University of Kentucky because of my work, but I was. And I had the great honor of walking into an amazing environment of colleagues in my College of Nursing and at the University of Kentucky who are experts in the field with tobacco control. So I would like to introduce one of our leading experts with the youth, with you guys, to see what she's doing to help us address the epidemic that we have going on with our youth that are juuling and vaping and everything else, and God knows what's in those products. So can I ask Dr. Melinda Ikes to please come forward? And I'm going to have you just stand there at the podium, if you would. So let me tell you about Dr. Ikes. She is actually an associate professor and director of graduate studies in the Department of Kinesiology, College of Education at the University of Kentucky, and she has a joint appointment with us in the College of Nursing as the co-director of our Tobacco Control Policy Research Program and director of Go Tobacco Free Kentucky. So this is a little bit of a change what I'm going to be doing, but I have recruited some students, haven't I? Yes, I have. So I would like the student that has question number 2 to please come forward, and you're gonna. It's gonna be fun. It's all good.
We're just rolling.
It's all
with
good,
it.
and just
go
have a
with the
seat
flow.
right
It's all
there for
good.
me, because what we're gonna do is when I call on for question number 2, we're gonna hear this young man's full name. We're gonna hear what school he's from and the town. We know it's from it may not be from the great state of Virginia. So you get it all out there, then he's going to ask a really hard question, Dr. Ikes. But not yet. And I have another volunteer for question number 3. Would you please come forward and have a seat at the front? That's it. Here we go. See, look at them. They had no idea. I know their teachers are just ecstatic that I've put them on the spot like this. We're having some leadership development. Thank you so much. And then we have someone who has question number 4. I believe it's over here somewhere, or over here. Yes, come on. Have a seat right up there. There we go. And then I've got question number 5. Here we go. Now that worked out pretty good. I did not handpick them. I just asked them to work it out at each of the tables. So we've got great representation. Are you ready, Dr. Ikes?
I am so ready, and this is more my jam. So
This
no
is her
offense
jam.
to the adults
This
in
is
here,
what she
but I
does.
like working with the young people and talking with them. So it's kind of weird that we're side to side. So I might be looking at them, but they're the ones that we really need to talk with about this issue. So I'm so glad that you thought of this.
Well, yes,
love
I
it.
did. Okay. So I'm going to do the first question, though, to get it going. So we have heard all of the news. It's just been really, it's been very disturbing, very sad, shocking to see how many individuals have literally died from vaping. So my question to you is the news, is this fake news? Or is it blown out of proportion? What's all the hype? Is it hype with marijuana in some of the products? Or is it hype with the flavoring? You tell us. Give it to us straight up.
Yeah, you know what? I wish I could say that it was all hype. Unfortunately, we've seen such a dramatic increase in young people using e-cigarettes and vaping. And how many of you in the room know somebody who uses e-cigarettes or vapes? Or you've seen a story about someone in the news who has used an e-cigarette or vaped, right? So it's really interesting because when we look at data from 2018, the report was about 3.5 million young people. So that means middle schoolers and high school. Many of you same age, right? We were astounded by that number. And then the most recent data came out in 2019 from national data, and we know that over 5 million young people are currently using e-cigarettes. And when I say they're currently using e-cigarettes, that means they're not just trying it, right? That means that they're repeatedly using in the past 30 days. So unfortunately, it's still an issue. The other thing that is important to consider is these products are changing daily. So while we were talking about Juul, which is one brand of e-cigarette a couple of months ago, we're now talking about things like disposable e-cigarettes. And so we have to keep up with the times because those numbers are going to keep going up if we aren't doing something about it.
Thank you. So now for the student who has question number 2, would you tell us who you are, where you're from, and if there's any stumbling with the question, it's because my handwriting is not really super good. So take it away.
My name is Dominic Ruiz. I am a senior at Albemarle High School in Charlottesville, Virginia. And my question is, why do you think the use of e-cigarettes and vaping has become so popular with youth?
I should be asking you all that question, right? So based on what we've learned, some of the main factors have to do with the appeal. So the first brands or the first design of e-cigarettes actually looked like a traditional cigarette. And so when those came out in 2011-ish, it really didn't take off among young people. So when these really sleek designs, you've probably seen them, they look like flash drives. They now sometimes look like key fobs. They look like those things that go on the back of your phones, the little wallets. When those sleek and innovative designs came out, youth were wondering, what is this? And so the design is one thing. The other thing that's really important when we're talking about young people has to do with flavors. So you might be surprised to learn that there are over 15,000 flavors of e-cigarette juice or e-liquid, which contains all the chemicals and the nicotine. Why in the world we need 15,000 flavors is beyond me. So when we're talking about flavors and we're thinking about fruit flavors, candy, many of you have probably heard of flavors like gummy bears, cotton candy. There are things called unicorn poop, zombie dust. I mean, that's certainly not geared towards the 45, 50, 65-year-old individual who may have been a smoker. So the flavors are really important. We know that actually over 80% of young people who start using any tobacco product use a flavor. And so that's why the whole idea of a flavor ban or legislation that includes all flavors is so important, including menthol. We also know that they're pretty easy to use, these new designs. So you can take a quick puff and then you can put it away and somebody might not see it. There's also ease of access. So that means they've been fairly easy for young people to get, which should be really concerning to all of us, right? We should not have a 17-year-old, 18-year-old being able to walk into a gas station or convenience store and purchasing these on their own or ordering online. The other thing is we know that they're really good at marketing. If we could kind of take some lessons on how some of these corporations who are promoting not so healthy products, they're doing a great job. So when the original marketing came out for some of these pod-based e-cigarettes, they were using bright colors, they were using young people, they looked like they were having so much fun. And so of course, that's gonna help young people to be curious about these products. And then the other thing I want to mention is the idea of social norms. So if you think that everyone is doing it, you may be more likely to try something, right? And so now in our day and age with social media, how many of you in this room have Snapchat, Instagram, TikTok, which I'm now learning about thanks to working with all the young people? So what they're telling me is, it's hard to go on your Instagram or your Snapchat and not see a story posted by another young person that's showing them using these products. And many of you are shaking your head because you've probably seen those. Well, these industries also pay what we call influencers. Anybody know what an influencer is? Yeah. So they're paying them to, post pictures of them using their products. There was actually a really interesting study that came out that there were over 1 million YouTube hits of people using e-cigarettes and vaping. So all of those things in combination, I know that's a really long answer. It has to do with why our young people are using these products. The good thing is those are all things that we can change. Those are all things that you all can make a difference in. And to say, enough is enough. We do not support these efforts to market towards us or to manipulate us. So I'm so excited that there are so many young people in the room because I hope you get fired up when you leave here today and then email me or call me and say, okay, I'm ready. What can we do?
Okay, now we're going to get a little bit harder with our questions, Dr. Ike. So question number 3.
Good morning. I'm Anna Grace Tomlinson. I'm a senior at Highland School in Warrenton, Virginia. My question is, you've done research with e-cigarettes with high school students transitioning to college. What did you learn from your research?
Yeah, so we did a study on our campus where we were looking at students transitioning from high school, so many of you similar age, to freshmen. And so they were traditional students. And we really wanted to know, so what's going on with this whole e-cigarette epidemic? And this was about 1.5 years ago now, which is crazy to think how fast time flies. But we found that almost a half of those incoming freshmen had ever used one particular brand of e-cigarette, which was Juul at the time. Think about that, almost half. So when you think of the young people coming out from high school and you know that they're already using these products on college campuses, we certainly have some work to do. We also found that there were certain risk factors. So, there's been a lot of research related to combustible cigarette smoking and other tobacco products and the risk factors. So with e-cigarettes, it's a bit different with young people. We know that white Caucasians are actually more likely to be using. Now, things are shifting, so this is always, something that we have to keep up with. It was also really interesting that those who intended to join a fraternity or a sorority were 4 times more likely to be current users of these products. And so that makes us go back to that whole social influence and, just thinking about the belonging, the connectedness, and how that could be really playing a role with this issue. The other thing that was really shocking to me is the current users had been using 20 to 30 of the past 30 days. So when we looked at current users, we found that over a third, so 33-ish%, were using 20 to 30 days. So just think about that. If you know what these products are like when we're talking about the pod-based devices like Juul, they have these little cartridges or pods, right? And so they have what we call e-liquid that contains nicotine, and that little pod contains the equivalent of nicotine of at least a pack of combustible cigarettes, when we think about our traditional cigarettes. And so there's a lot of nicotine in these pods, and young people are using more than 1 pod a day. And so that risk for dependence becomes really concerning. The other thing when we're talking about dependence is many of these incoming freshmen were using other substances. So current users were 6 to 8 times more likely to also be current marijuana and current alcohol users. And so when we're talking about substance use and substance dependence, it's really hard to talk about one product in isolation. And a lot of the things are similar when we're talking about prevention, which I know we'll get to, but we need to work collaboratively to truly see a difference. And then finally, our lessons learned. This is something that students, incoming freshmen, they were initiating over time. So as they had other influences, like their social influences, some environmental influences, they were still likely to initiate throughout their freshman year. So we had such a large population of young people that were already using, but we still had to worry about prevention. So it reinforces the importance of prevention, but also treatment.
Thank you. So let's shift gears a little bit for question number 3.
My name's Joe DeWolf. I'm a junior at Highland School in Warrenton, Virginia. And my question is, what are some of the misperceptions young people have about vaping?
Yeah, what are they, right? So, I think one of the biggest things that the media and the industry, the industry has done a really great job of is saying, these are not that bad for you, or they're much safer than combustible cigarettes. And that's a message they want to get across. Why? Because it helps sell their product. But we now know, there's research coming out every single day. I'm the kind of person, do y'all know what Google alerts are? So I get Google alerts for e-cigarettes and vaping. You can imagine how many hits I get every single day. But it's hard to keep up with the research because so much research is coming out on the health effects of e-cigarettes. And reputable research, from people that have been doing research for a long time. And so while the long-term evidence takes a while to get out there, we know enough, and we know that these products are not harmless. And it's important to consider that less harm is not the same as no harm. We also know that these e-cigarettes contain a lot of different chemicals, and because we're kind of in flux right now with the regulation and when we're talking about how these products will be regulated in the future, we really don't know what's in them. We couldn't list all the chemicals, we couldn't list the percentage of nicotine concentration, but we do know that there are cancer-causing chemicals in many of the e-liquids that have been studied, which when we're talking about cancer prevention, that's really an important point. We also know, how many of you have heard that it's water vapor that comes out? Anyone? Yeah, guess what? It is not. So we know that it's aerosol, and aerosol contains fine are ultrafine particles, which are really easy to inhale into your lungs, deep into your lungs. And we also know that these chemicals, or the aerosol, when it's emitted, it contains chemicals. It can contain things like fine or metals. And so one of the things that I think is you're going to hear a lot more about in the coming months is this idea that you, the bystander, you're being exposed to secondhand aerosol. So if your friend is using and you're breathing that in, you're actually being impacted, whether you realize it or not. And so that's something that I think you can take back with you, hopefully, and it resonates with you because we've learned so much about secondhand smoke exposure, and I feel like people are really good at articulating why they don't want to be around secondhand smoke, and now we're talking about secondhand aerosol. So those are some of the health misperceptions. I also think that there's a perception that everyone's doing it, and a lot of that is perpetuated by social media. And, what we do know that if young people believe that everyone's doing it, they are more likely to try it. And so how do we shift that gear and say, guess what? I'm not doing it. You're not doing it. There are more of us who are not doing it than who are. And so that's a message we need to get out as well.
So we've got the $1 million question coming up with number 5.
Hello, my name is Abigail Fielding, and I'm a senior at Monticello High School in Charlottesville, Virginia. And my question is, what will help combat this issue, and is there something to help treat those that vape?
Yeah, so my first response is you all are the answer to helping combat this issue. Every single one of you in this room, you can help educate, promote awareness of fact-based information. You can have conversations with your peers, with your parents, with your administrators, your colleagues. I think we need to have open dialogue, but we do know that several things work. So for years, we've studied tobacco prevention in schools and with young people, and we know things that when we talk about refusal skills, decision-making, how to empower young people, all of those things resonate and actually last long-term. And so right now, for example, we are working on an e-cigarette prevention and empowerment program. It's called I Can End the Trend. Oh, I'm sorry, I'm supposed to say the hashtag. Hashtag I Can End the Trend. And so I have had the most wonderful experience working with young people. And so working with college students who help develop and design this program to be relevant for young people. Because guess what? I mean, I still like to think I'm cool and hip, but I'm getting to that point where I might be over the hill. So I need to know, how do we talk to young people about this issue with things that are going to resonate with them? I can talk about the health effects all day. I can tell you the statistics. They're not listening, right? You all might be, right? Because you're way up here. But we know that most people, that's not going to really stop them from trying these products. Things that stop them are, again, those refusal skills, feeling empowered, understanding that they're being manipulated, how much they cost. And so those are all things that my college students helped me to integrate into our program. So trained college students go into schools, elementary, middle, and high schools, and we do a prevention curriculum. The biggest piece around that is that empowerment. So, and I love that I've heard that from several of the speakers today, because we really can empower you all to be the change that we wish to see. The treatment piece is also important. So while we're talking about prevention, we know that so many young people are already using and they are dependent. So they're having physiological withdrawal when they are not using these products during the school day. And so how can we support them and set them up for success? And so there have been, just really in the past 6 months to a year, there have been a couple of national programs that have been launched. Truth Initiative has one. It's a text-based program. And then National Jewish also has one called My Life, My Quit. And so we're realizing that while a lot of the same lessons we've learned with tobacco treatment for adults and young people are similar in terms of the approaches, we need to get down on the level of young people and communicate in ways that they understand and ways that they're used to by texting and bots and videos. And so some of these new platforms integrate those strategies. And then finally, this is a really long-winded answer. We know that policies help. And we all need to be advocates for these policies. So when we're talking about flavor policies that include all flavors, including menthol, with no exemptions or no loopholes for these little lovely disposable e-cigarettes that we're now seeing pop up everywhere in our schools. We also need to think about taxing these products, at the same level or parallel to how we're taxing others. And then we need smoke-free policies in our communities. They need to be comprehensive, and they need to include e-cigarettes. And similarly, in our schools, we need tobacco-free policies, and we need to make sure that there's support for implementation. We need to make sure that we're offering that treatment and that they're also being really clear on what products are included, like e-cigarettes. And then we also need to go back to that treatment, and treatment becomes so important. And so do we have the resources in place? Do we have, in each school, in each county, is there someone that's trained that these young people can go to? All of those things have to happen for us to make a dent in this epidemic. But I think with all of us in the room, those are certainly possibilities.
So thank you so much. How about if we give a round of applause to Dr. Ikes and our fabulous student panel? You guys are awesome. I hope that your teachers are taking note, and it's going to be an A for today for you guys. So do we have time for one or two questions? Or?
But I want to make sure we get a picture with everybody.
Oh, yes.
We have time for questions. Does anybody have a question for any of the doctors, students? Right over there. Can you stand up and just shout it out?
When you say taxing, so you said like making them more expensive, don't you think that could possibly make it easier for people to like black market and stuff like that and make it more poisonous? So don't you think we should focus more on the health side of it and focusing more on
Yeah, I mean, I think that is a wonderful question. And when we saw the kind of the vaping epidemic come on the news, where we're talking about lung and respiratory illnesses, a lot of it came back to find that, young people were buying things on the black market, if they call. That is one facet of the e-cigarette epidemic. And I think we do need to engage young people, but we need to look at all of those strategies to see what's going to be most effective. And it's probably not going to be just taxing things, right? At the same time, we need to be to ensure that we're in the schools, that we're educating, that we're having young people understand the facts about these products, and that they're, potentially putting themselves more at risk if they're purchasing products from, not necessarily a convenience store or a gas station. But at the same time, we know that those products that are being sold in stores where it's legal, those are still not harmless. And so I think that's a message that got mixed a little bit with the media, focusing so much on these deaths, it's awful, and it's something that's very concerning. But the nicotine-containing products also have a lot of harm, and those are products that can be purchased legally. So I totally understand what you're saying, and I think it'll take all of us to figure out that solution.
Right there in the white sweater. You want to stand up and shout it out.
So I know like how you touched on a big part of it was like kind of social norms, and for the youth that want to speak out and the student leaders that want to speak out against it, is there a way that they can speak out, or like have you thought of like a way for them to speak out in a way that doesn't like get them criticized by their peers?
Mm-hmm. That's a really good question, and that's something we hear in the schools quite frequently is, there's something, I want to do something about this, but I'm a little afraid to stand up. Am I going to be bullied? I think we are the ones that have to change that culture. We're the ones that have to be the leaders and to say, it's okay not to use these products. And there are some really great videos out there where we have athletes talking about, how this impacts their athletic performance and why they don't want to use them. We've also had individuals who have used these products and become dependent. If anyone has heard of Luca Kennard, he's like my favorite. He's a young man who's in high school, and he talks about his story, and he talks about how he became so dependent on it. But guess what? He flipped that narrative, and he is now an advocate, and he works with organizations like Campaign for Tobacco-Free Kids and Truth Initiative to share his story and to use it as a platform to say it's time for all of us to speak up. So, not everybody has to go through this. But I'd love to chat more about ideas.
Okay, I'd like to ask the doctors, the panelists, and board members to just quickly come take a picture.
That means you guys.
Board member,
you.
I'm glad to have you guys be part of this. Students, come here one sec. These guys right here. There you go. Thank you for being part of this. You were
Thank you
great.
so
You guys were great.
Thank you.
Really good. Thank you. Thank you
so much.
Thank you. Appreciate it. Thank you. So good. We all. Who loves this Dr. Janie Heath? Is wildly cool. We're so lucky to have all of these people and their creativity be part of this. I think what we're going to do is to jump to our Elsie Hillman speaker. Is that okay, David? So Elsie Hillman was a friend of mine, and she was a great promoter of women leadership models. She really encouraged women to run for office, Republican or Democrat. She was a high energy, great person, great friend to me. And our next speaker, our Elsie Hillman speaker, is actually Governor Gretchen Whitmer from Michigan. And we have asked her to be the speaker because of her position on vaping. And I want you to see this. We were very excited to get this. She responded almost instantly to wanting to be part of this. And so, Governor Whitmer.
Hi, everyone. This is Governor. I'm so sorry I couldn't be with you in person today, but I'm proud to congratulate the hard work you've done, raising awareness around cancer prevention and risk reduction. This is an issue that's very close to me. I lost my mom to brain cancer in 2002. I took care of her at the end of her life, and since then, I've worked hard to ensure that everyone in Michigan can access affordable, quality health care. I know how hard it is to lose a loved one to cancer, and how important it is for people to take preventative measures to lower their risk when they can. That's why last year, when I was governor for my first year, I announced a statewide ban on flavored nicotine vaping products. These products can contain harmful chemicals that can lead to severe respiratory disease and put our kids' health at risk. The data could not be more clear. Our kids are getting hooked on nicotine because vaping companies are marketing flavors like cotton candy and apple juice and bubble gum. They're making our kids think that vaping is safe by using terms like clean and healthy. Because of this, we've seen an explosive rise in teen vaping in the past few years alone. This is one step we are taking in Michigan to keep our kids healthy and prevent harmful diseases. And I'm committed to continue working on other preventative measures, like making sure people have the opportunity to put healthy, nutritious food on the table for themselves and their families, ensuring that everyone has an opportunity to get active, and continuing my work to expand healthcare to people across our state. Thank you for the work that you do.
We appreciate what she's done, banning flavored vapes in I think they were the first state. So next up is the John Dingell Disparities Panel. We wanted to do this in honor of John Dingell's memory because it's a year in the next couple days that he passed away. He is from a great family that has served in Congress for many years. His wife, Debbie Dingell, is our sponsor. She was a sponsor of the United States Bipartisan Cancer Prevention Caucus yesterday, which we initiated. And she is the sponsor of the resolution, National Cancer Prevention Day, which is also something that we initiated for February 4th, which most of you know is World Cancer Day, but you know, when I first caught the wind of those sponsors way back, I thought, wow, that's just not a way to prevent cancer. So we came up with a day that we really wanted to work to make a difference, to change the world, and to change it in a real way. So I'd like to turn this over. Where is Dr. Gardner? Please come up. And Dr. Gardner is going to invite. We're very lucky to have Dr. Gardner here with us because she helps us with all our public health credits. She's from American University. How long have you been doing this for us? 5 years? Yeah. Yeah. So we're super glad to have her. Would you like to be at the podium or here? Yeah. Podium. I'm going to turn this over to Dr. Gardner. Thank you.
Hi, everyone. I'm happy to be here with you today. And I am going to be the moderator for this panel, and the panel will focus on disparities in cancer prevention. And we know that disparities exist in exposures and prevention programming and even access to healthcare and services, as some of our previous speakers have alluded to. And the work of the 4 dedicated professionals that I'm going to ask to come forward in a second highlights the critical issues in all of these areas, and we are so honored to have them with us today. So, without further ado, I would like to ask Mee Stanley to come forward, and also Dr. Tom Oldrich. Thank you. Dr. Kelly Herko. And Sana Chehemi. So each of the panelists is doing really interesting and varied work in terms of disparities associated with cancer. And they've provided me with some questions and I guess I should say kind of cheater notes so that I can ask them some informed questions. So I'm going to do that one at a time. And we are going to start with Mai Stanley. And let me tell you a little bit about Mai. She is the Communications and Marketing Manager at Traverse Health Clinic. She holds an Associates of Arts degree from Northwestern Michigan College and a Bachelor of Arts from Michigan State University and a Master of Fine Arts from Syracuse.
Well, thank you so much for inviting us to be part of this very important event today. So Traverse City, for the way that I usually introduce Northeasterners to the area that where our clinic is located, is kind of like a Cape Cod on fresh water. So it's a fairly affluent, really beautiful area that has still has some poverty underlying and issues of access that we, as a FQHC, Federally Qualified Health Center, work very hard to address.
Okay, great. Can you tell us what some of the specific health disparities are that your patient population experiences?
Sure. So as an FQHC, we are located in an area that's designated as medically underserved. And the very specific neighborhood where we're located, the median income is about $38,000 a year. So, and about half of the housing stock there, if for the people who own homes, has a value of less than $100,000. So we're talking about an area that has very disproportionate level of poverty relative to an affluent region. And across the country, 1 in 3 people who live in poverty are served by a federally qualified health center. And so what we're looking at in terms of how Michigan has been one of the states that expanded Medicaid, and that has been a huge benefit to getting access to care. And our health center provides integrated primary care and behavioral health, and that's accessible to anyone. So everyone is welcome, whether you have private insurance or Medicaid or no insurance at all. No one is ever turned away because of an inability to pay. And so what's really important to us, though, is it's not just giving access to healthcare, it's access to high quality healthcare. So some of the things that we're particularly proud of are, for instance, our cervical cancer screening rates. So nationwide, it's about 56% of women are getting their cervical cancer screenings as recommended. For our patients at our clinic, that's almost 71%. So that's huge. We also, in terms of obesity, for adults being screened for their obesity and then follow up with counseling about nutrition and healthy activities. Nationwide, it's about 70% of patients who get that, and it's about 82% of our patients. So these are some of those risk factors that we know are modifiable with behaviors, and we really try to put our providers are all very interested in putting the patient in charge of their care plan. If someone has a diagnosis of depression when they're in with their primary care provider, they can get a warm handoff to a counselor or therapist who's just down the hall. And 90% of the patients we serve are at or below 200% of the federal poverty level, which means these are working poor people who are really struggling to make ends meet. Over half of our patients are below the poverty level. So this really is, we have about 3,800 people that we serve every year, and they are people who would probably go without access to care if we didn't exist.
Oh, my goodness. Thank you for giving us just a snapshot of the incredible work you're doing. It's one thing to talk about providing access, but it's a whole nother thing to actually provide access to high quality care. So bless you for that amazing work. We thank you. Next, I'd like to turn to Dr. Aldrich, and I'll tell you a little bit about him. He is the Deputy Head of Global Oncology, the Fred Hutchinson Cancer Research Center. He is the Deputy Program, I already said that, I'm sorry. He's also Associate Professor of Medicine at the University of Washington, Division of Medical Oncology. He is a principal investigator and a member of the Steering Committee of Cancer Immunotherapy Trials Network. His major research interests are the pathogenesis and management of virus-associated cancers, including those that occur in the setting of HIV. So, with that introduction, I was wondering if you could tell us a little bit about the work you're doing, particularly with the ANCHOR study, and maybe even then discuss a little bit about the risk for anal cancer and cervical cancer and breast cancer associated with HIV.
Great, thank you. Is this on? Thank you for the introduction. So just as a way of background, my work, I'm a medical oncologist. I trained in treating people with cancer, but also trained in cancer epidemiology, and for the past decade or so have been really focused on viruses that cause cancer. And so I think it's important to think of this in the context of array of viruses that cause cancer. About 1 in 6 cancers globally is caused by an infectious disease. And this is my 3rd year at this event. And really the reason talking about it is so important is many infection-related cancers are probably preventable. We know that there are several viruses, including HPV, which causes anal cancer and cervical cancer, which I'll get back to in just a second to answer your question, that cause various types of cancers, including head and neck cancer, cervical cancer, and anal cancer, hepatitis B virus, which causes liver cancer, Epstein-Barr virus, which is a virus that was discovered in Uganda, which causes lymphoma, and a similar virus called Kaposi sarcoma herpes virus, which was first discovered in AIDS patients in the 1990s in the US. HIV is an interesting virus. All the other viruses I talked about are directly found in cancer cells. HIV increases the risk of a range of cancers by not directly, but by affecting our immune system and our immune system's ability to control cancer. And so there's a lot of prevention that can be done just around HIV. When you look at cancers that occur in the setting of HIV, there are about 8 that predominate, and those include Kaposi sarcoma, lymphoma, cervical cancer, anal cancer. These are all caused by viruses, as well as smoking-related cancers, including head and neck cancers and lung cancer. Really figuring out the best way to prevent cancer in this patient population is multifold, and we can talk about some of them, but directly to answer your question about cervical cancer and anal cancer, really, for people who are already infected with these viruses, HPV vaccines are unlikely to be effective. And so really the approach needs to be screening approaches. Cervical cancer screening programs, such as have been discussed, sometimes need to be tailored to people with HIV. In addition, we know that cervical cancer prevention decreases cervical cancer, screening programs prevent cervical cancer by probably 80% or more. In theory, we should be able to do the same thing with anal cancer. There's 80% of the cancers of anal cancers are probably preventable, and yet we don't really have a good screening program for them. The National Cancer Institute is conducting a study called the ANCHOR study, which is trying to take the concept of cervical cancer screening and applying it for anal cancer screening. So it's a long answer to your
No, that's
question.
great. That's great. So I'm thinking of the audience here, and that we have so many folks that are under the age of 18. And I'm wondering, I know you didn't provide this question, but I'm wondering if you could provide some advice on HPV prevention and some of the recommendations around vaccination and things like that.
Right. So really, the HPV vaccine, and there's a couple of HPV vaccines, but all of them target the two commonest. The HPV, there's probably 70 or more strains of the virus, and certain of them are high risk of causing cervical cancer and anal cancer and oropharyngeal cancer. Those are cancers of the tonsils. Are caused by a certain high-risk HPV, and 16 and 18 are the commonest ones. And there are several vaccines that target these strains of HPV. There are very effective vaccines that have been FDA approved for prevention of any HPV-associated cancer, and really the use of these should be before people become infected with HPV. And so the recommendations are to start vaccination with teenagers and extend into young adult and increasingly older patient population. So really the most important message is that really all adolescents should be vaccinated with HPV, and the uptake of this vaccine has been relatively slow. There are some controversies of whether it should be for just girls or girls and boys, but the recommendations are really quite broad, and I think the benefits will likely play out for all of these types of cancers.
Great, thank you. So those of you that are of the younger set maybe have something to investigate now in terms of personal cancer prevention. Thank you, Dr. Ulrich.
Sure.
I'd like to move on to Dr. Herko, and I will tell you a little bit about her. She is an assistant professor in the Department of Epidemiology and Biostatistics in the College of Human Medicine at Michigan State University. Her research aims to understand the etiology of cancer through the investigation of modifiable lifestyle risk factors, particularly obesity and nutrition, to reduce the overall burden of cancer. She is interested in using biomarkers such as sex steroid concentrations and tumor marker characteristics to illuminate the pathways through which exposures to certain lifestyle factors may result in the development of breast cancer. So I have a few questions for her. The disparities that she is particularly interested in talking about today have to do with disparities for our rural population. And so I'm wondering if you could talk a little bit about some of your research and particularly that research around broadband access and the lack thereof.
Sure. So just to provide a little bit of background, I'm employed by Michigan State University, but I am a community-based researcher, so I am actually physically located in a rural part of northern Michigan in Traverse City. So I have done some research on racial disparities in my training, but now that I'm in a community that is rural, I've gotten interested in understanding some of the determinants of rural disparities. And one of those factors that has become apparent is the lack of broadband internet access in many rural parts of our country. So in urban areas, about 97% of adults have access to high-speed internet, but that drops to about 65% of Americans in rural areas, and it's even lower in our tribal communities. It's about 60% of adults having access to that. So, there's about 30 million Americans that are estimated to not have access to these services, and that really means that they can't reap all of the benefits of the digital age. And as we know, there are so many ways that broadband access can impact health and the delivery of health care. So for example, telehealth programs and mobile health programs have really incredible potential to reduce health disparities and kind of improve the healthcare access in the communities. But unfortunately, those communities who would stand to benefit most from those technologies are the ones, those are the rural and the underserved populations. Those are the ones that are least likely to have access to the broadband internet that's necessary to deploy the technology. So I've been really interested in working on efforts to promote internet access as a social determinant of health. We know that internet access also leads to educational opportunities and employment opportunities, so it directly impacts the social determinants of health and should be considered actually as one of those social determinants of health and something that we can use to reduce rural cancer disparities.
So I have a follow-up question for you. Your team recently published a policy brief, and I'm wondering if you could summarize for us your recommendation on policy markers to reduce that digital divide you just discussed.
Sure. So I was part of a large national team that published a policy report to ensure that we can promote and protect the National Broadband Plan, which was enacted in 2010 to improve access to internet in rural communities and other communities around the country. So we, as part of that report, recommended to Congress to provide support for communities and how they can effectively implement the plan. We also asked for further funding. When you are trying to build infrastructure for internet to connect remote communities and geographically dispersed areas, it's a lot more expensive. So currently, the funds that were appropriated for this effort are probably not going to be sufficient to do that. And then finally, the third recommendation from that report was to address the fact that how rural communities that were appropriated these funds was decided based on a population estimate. So any community that was 20,000 people or less, according to the census, were prioritized. And our team felt that these efforts could be more targeted to communities that perhaps might not be at that cut point, that arbitrary cut point of 20,000, but perhaps there are communities where there are 22,000 residents, but they have a high cancer burden and low access to specialized care. And so we promote using existing public health data to really target those interventions and not just use that arbitrary cut point of communities that are 20,000 people or less.
Great. Thank you for highlighting something that I think a lot of people don't think about as a social determinant of health. And obviously, if we have all this amazing technology, but people don't have access to it, it doesn't necessarily achieve the results we want. So I thank you for that research. Okay, now a little bit of a transition. We are going to move on to talking with Sana Chehemi. Am I saying that correctly?
Perfectly.
Oh, perfect. She is the Director of Policy and Advocacy at the Prevention Institute, and she leads their federal engagement and partnership outreach efforts by directing the organization's policy and advocacy portfolio aimed at supporting upstream prevention policies and investments to advance health, safety, well-being, and health equity. As part of the Health Systems Transformation Team, much of her work focuses on shifting perspectives on policy, strategic communications, and developing partnerships to promote community prevention practice. Oh, okay. All right. And so, Sana, I'm just wondering if you could tell us what it means to apply a public health approach to cancer prevention.
I would love to do that. How's everyone doing? Good? Or if you need to like stand up, stretch, or get the blood circulating, please feel free. I won't take it personally. We've heard the term risk factor a lot today, at least from the moment I stepped into the room. I've heard the term risk factor a lot. And taking a public health approach to cancer prevention means addressing those risk factors that are based in our communities. So that this is not, that go beyond our personal individual risk factors, but how do the places we live in, the places we learn, where we go to work, how do those communities either protect us from developing certain cancers or contribute to the likelihood that we may develop cancer? And so we heard earlier that risk factors for breast cancer, for instance, are our weight, our ability to exercise, how much alcohol we consume. And on one level, those may seem all like individual choices and behaviors, but if you take a step back, they're also really influenced by our community context. So we can't eat healthily if we don't have access to healthy, affordable, culturally appropriate food in our communities. And we may take it for granted that we can buy healthy food, but for many, many communities of color, low-income communities, being able to easily buy healthy food is not a reality. So that's an example of how that risk factor of being overweight is not entirely within that individual person's control. It's a public health issue. It's a community issue. Same thing with our ability to exercise. Can we move around freely and safely in our communities? Are there sidewalks? Are there safe parks and playgrounds? These are all public health implications that can impact our risk for cancer. Consumption of alcohol. Are we living in a community where there's a greater density of alcohol outlets? Are we living in an environment where we face toxic racism on a daily basis, where turning to alcohol might be a coping mechanism? These are all public health implications. And then there's the flip side, that what our communities look like and the decisions that are deliberately made about what's available in our communities can also have can be protective. So we can choose to invest in healthy food choices. We can choose to invest in active public transit. We can choose to make sure that there are bike lanes and safe sidewalks. We can reduce alcohol density. We can make sure that breastfeeding is supported. We can put in place workplace policies that allow everyone in a workplace to be able to breastfeed. So these are all examples of how we can kind of take a step back and look at how our communities are supporting us, or how our community conditions are might actually be contributing to our risk of developing cancer over time.
Great. Yeah, I think it's really important to highlight that this is a public health issue, and there is much we can do individually, but there's even much more we can accomplish if we approach it on a community level. So I was going to ask you if you could tell us about some successful strategies. You've alluded to that a little bit. Do you have any specific examples that you'd like to share with us?
So I think, the example that everyone, is probably thinking about is tobacco control, right? So once there started being links between use of tobacco products and increased risk of lung cancer and other cancers, the approach to that wasn't merely, well, we're going to tell people that they really need to quit smoking. It was also, we're going to ban smoking from airplanes. This side of the room does, it probably is unimaginable that there was ever a time when people could smoke on planes. I'm guessing that this side of the room has probably been on some of those flights where people smoked. I'm still not sure why they still have the ashtrays for gum, I guess. So clean indoor air policies, things like not allowing smoking in public places, in parks, not allowing smoking on beaches within a certain number of feet from a school. These are all comprehensive kind of public health policies and approaches that were put in place at the same time that there were treatment and cessation programs. We can take a similar approach with how we're ensuring that there is food access, how we're viewing active transit, as a public health issue, but also potentially as a protective factor for cancer prevention. So there are a lot of existing public health policies that are being championed that aren't necessarily being framed as part of a comprehensive approach to cancer prevention that should be. We might have more collective success if we start framing some of those common public health approaches as also one of the tools that we have to prevent cancer.
Great, thank you. That was wonderfully phrased and a perfect example. So I would like to open it up to the audience now to see if anyone has any questions for any of our wonderful panelists. They're all doing pretty amazing work and just were able to tell you a small snapshot of that work. So any questions for any of them? Here's one.
Yeah, what are the limitations to having those federal like clinics and stuff? Like, why are there not more implemented in every?
Well, they're actually across the country. There are close to 1,400 federally qualified health centers, and that operate almost 12,000 sites. And some of those are in schools, and some are in public housing. So the limitation is that it needs to be in a quote medically underserved area. And then we, in addition to being open to everyone, we have a sliding fee scale. And so that's for people who are at or below 200% of the federal poverty level. We can offer them a discount on their services if they're uninsured or underinsured. And so it really is based on the demographics of that area. But with 12,000 sites across the country, 1,400 being run by 1,400 centers, there probably is a community health center, an FQHC, nearby where you are, wherever you are. And if you want to find that out, go to HRSA.gov, and they have a tool to look up your health centers. And if we want to talk about overcoming health disparities, I think health centers have been doing a great job for over 50 years, and they have strong bipartisan support for the work that, that we're doing at them. So that's really exciting. Great question.
That was a wonderful question. Thank you. Here's another one.
This is sort of for any of you, but when you're talking about disparities in healthcare, disparity that often comes up is race, and especially I was just thinking with dark waters and then Flint, Michigan, obviously there's a difference in the majority race of the population. So what can be done when you have something like that, where there's a big medical issue in a minority community that's not getting money or attention or like medical care that they need?
That is an awesome question. Who wants to be brave? And okay, Tom.
I can comment as it relates to HIV, which is something I understand best. HIV in the United States in particular disproportionately affects communities of color. And really, it's important to think of HIV prevention as cancer prevention and HIV treatment as cancer prevention. And so in the setting of HIV, there's been recently an increased push policy-wise from Secretary Azar to end HIV in the United States. That's by implementing goals of what's called 90-90-90. That means 90% of the people who are HIV infected know they're HIV infected, get enrolled in treatment, and are effectively controlled on antiretrovirals. That's done by measuring the virus in the blood to make sure that it's not detectable. And so the efforts to do that are through large organizations, through academic centers called the Center for AIDS Research, where monies are being spent to target specific communities, particularly communities of color that are at highest risk of getting HIV, and trying to implement prevention programs in those communities. So for the setting of HIV in the United States, that's one way that cancer prevention through HIV prevention is taking place.
Can also add, I mean, I think part of the approach is also rooted in being willing to name the problem and you know, name racism and discrimination as a leading driver to why there are inequities in health outcomes, and being willing to say that you know, health inequities they're not accidental. They're the result of very deliberate, both deliberate historical decisions, but also deliberate like present day decisions. Like it was a very deliberate decision in Flint, Michigan that led to them deciding now we're going to get the water from over here instead of, you know, over here, and we're not going to respond right away. And having people who are willing to call that out and name the underlying problem and not shy away from that is really important in order to actually develop comprehensive solutions that are going to address racial or health inequities.
One additional follow-up comment. I think was just reminded an important component of all the efforts has been to include the communities that are most affected. And so for the HIV prevention, for example, there are community advisory boards and community participation in all the efforts that go on. And that's really central to the success of any of the programs that are for HIV prevention.
So let's take this one step further. And Kelly, can you talk a little bit about rural? Because in dark waters, they're specifically talking about corporate, deliberate decisions by corporate that totally support an entire community economically, from employment and all of those kinds of things, but also can control and limit access to other things. So can you talk a little bit about some of the unique things about rural environments in terms of employment and how those things affect?
Yeah, and I will say, you know, with the Flint population, it definitely disproportionately affected the African American community, but it disproportionately affected people living in poverty. So it wasn't just, you know, a racially motivated decision necessarily. So there's, you know, it's tricky because when we talk about rural cancer disparities, often we think about mortality disparities, and it's most likely closely tied to those socioeconomic factors that we know are very important for health and health outcomes. And so it's often difficult to disentangle the role of socioeconomic status with the rural disparities. So some of the research that's looked at cancer rurality and cancer mortality, when they account for, in our models, when we account for the socioeconomic status factors, either those relationships are severely attenuated or, in fact, sometimes even disappear. So we know that socioeconomic factors are really important for some of these, but there are other factors as well. You know, educational programs that are built to raise awareness. This goes back to the broadband internet access. If you're not having access to that information, then you don't have the knowledge to be empowered. Another factor with rural communities is that they're disproportionately older, so the population age structure is significantly different, and that influences that as well. And there's factors that we don't know as well, but those are probably the main ones, I would say, is the age structure, the poverty factors, and the dissemination of information and lack of broadband access, how that impacts those communities.
So do we have time for one
Sure,
or two more
sure.
questions?
We are going to be moving into lunch, and then Representative Byer should be here shortly, so
Okay.
it's going to be a little bit of a liquid experience, but
Okay.
sure, get some questions here.
Okay, so I'm not really sure how to word my question, but like I want to know if you guys have ever dealt with like LGBTQ discrimination in like healthcare and stuff like that, dealing with like cancer, and, like the lack of LGBTQ healthcare. So this is kind of open for any of you guys.
So one of the things that, as a health center, that our mission is to ensure that no one's health gets left behind and to serve medically underserved populations. One of the things we've tried to do is think about what does that mean? Who is a medically underserved population? And in our community, which is a fairly rural community, that certainly includes the LGBTQ population. And so we've started doing direct outreach to that community. We're very proud to be part of, there's something called the Up North Pride Week, and every year, for the last 3 years, we've gone to the Up North Pride Picnic, which is over 5,000 people at the last time, to share information about our services, because we aren't just medical care, we are behavioral health services as well. And we're working hard to be designated as a healthcare provider of choice with our local LGBTQ community youth center. So that's something that's very important. We know that there are disparate health outcomes for the LGBTQ community. And so even in a rural setting, that is a community we have made a point of doing our outreach to.
I just want to add quickly that one thing that is impeding research in that area is that we're not really collecting that data in the health records. And so I know there's a lot of push now to collect that data so that we're able to have those conversations in the clinic, because we know there are disparate outcomes, but we have to be able to measure that in order to study it.
Thank you for your question. That's a very important question, and certainly the HIV community has been dealing with that in the United States. The LGBT community is disproportionately affected by HIV and continues to be the highest at-risk population, and cancers in this patient population remain an important problem. And so you cannot address HIV-associated cancers in the United States without addressing LGBTQ health.
Okay, thank you for that great question. I think that
I think we're going to wrap this panel up, and then we're going to hear a little bit from Sana, but I also wanted to say, too, that while these people are great at identifying solutions, they are the same people, identifying problems, they are the same people. Thank you. They are the same people that create solutions for so many of these problems. And so while scientists and public health experts, they also are thinking creatively about bridging gaps. And I personally am super honored and grateful that you're here working working on those efforts. So let's give them a big round of applause. If it's okay, I'd like to have you stay right where you are, and then can you tell us a little bit about your organization? You're going to get up and
Sure. I'll just do, I'll just do like 2 minutes because I'm between you and lunch. So Bill very, very kindly said that I could have an opportunity to just talk a little bit about Prevention Institute. Maybe you want to pursue a career in public health. We need more of you. So Prevention Institute, we're a national nonprofit. We've been around since 1997, and we're committed to health, safety, and well-being through thriving, equitable communities. And so our focus is very much on what can we do to prevent people from getting sick or injured in the first place. So as I mentioned earlier, how do we design and structure community environments that support health, safety, and well-being? What are all the things that can be done system-wide and structure-wide and policy-wide before people have to go into the doctor's office? And so we kind of work to shift the understanding of health as broader than health care. Access to quality, affordable health care is really, really important. And much of what determines our health is actually shaped by where we live. We also work to shift the focus from one individual at a time to a population, so to entire communities. All of our work is rooted in health equity and racial justice, so really paying attention to what we do to prevent inequities in health outcomes, and to really put forth this message that prevention is possible. Cancer prevention is possible. Preventing violence, multiple forms of violence, is possible. Preventing type 2 diabetes, that a lot of the chronic conditions and illnesses that we kind of take for granted now in our modern day society, much of that could actually be prevented, and there are tools and resources available to do that. So I invite you to visit our website. It's Prevention Institute, all one very long word, .org. And all of our tools and frameworks are available free of charge. And if you're interested in anything, please feel free to reach out.
That was
Thank
great.
you.
Really great. Thank you, everybody. If it's okay, is Missy here? Miss, can we come over and we'll take a quick picture if that's all right with everybody? Can you? We'll just do this group here, if we can. No, in front of the screen would be great. Just because we have a time thing here. That was great. Really good, everybody. Thanks, Missy. Okay, everybody. Oh, he is. Where is he? I don't see him. Oh. Where's Donna Eco? There's her friend. There you go.
Hi. We'll make this fairly brief. Hi, Don. Because lunch is next. Sorry, Don. It's my great honor to introduce my dear friend, Don Beyer. He is the representative from Virginia's 8th District, which is Alexandria and Arlington primarily, and has had that position since 2015. He also served as U.S. ambassador to Switzerland and Liechtenstein from 2009 to 2013, and prior to that was Lieutenant Governor of Virginia and has run a very successful business in this state as well. Mostly we know him as a longtime supporter of less cancer, for which we are so grateful. He is also a great advocate for reducing health disparities and safeguarding drinking water, two things that are very important to us, and we appreciate your efforts on all of those. So thank you for coming by to say a few words.
Thank you, Donna, very much. Well, thank you. This is one of the highlights of my year because I get to be with the former First Lady of Austria, Ms. Eco, who taught me how to do the Australian waltz ballroom dancing. Yes, yeah, incredible. Yeah, Austrian. Yeah, I get them confused. There it is. Different hemispheres. All that. But thank you very much. I'm really, this is something that needs to be close to everyone's heart. I lost my mother to cancer. I lost my younger sister to cancer. But things keep moving in the right direction. Right now I have a nephew's wife and my sister's ex, both with serious stage 4 cancers, both with the new treatments that are doing wonderfully, both in complete remission. One of my closest friends is an oncologist in Arlington, and his success ratio now, based on all of the research that you guys have sponsored and are funding, is making an enormous difference in our lives. 3 or 4 quick facts. Number one, our smoking rate now is less than 15%. Only Australia, not Austria, is lower in the whole out of 190 countries, and that's down from the mid 40% when I was a high school student smoking unfiltered Camels every day. So we've come a long, long way, which is making a big impact. A second big thing is we're really drilling down on different cancer rates in different populations. So you look at Native Americans or Alaskan Inuit, you see much higher rates of liver cancer, there's a whole list that I won't read to you, but when we realize that specific populations are at risk for certain kinds of cancers, our research makes a big difference, and we can go a lot farther. Despite efforts by certain people in the executive branch to cut the NIH budget, Congress, year after year, in a bipartisan way, has been pumping up NIH by a couple of $1 billion a year. So we see Dr. Francis Collins regularly, and that's a very exciting thing. I remember, wasn't that long ago, 10, 12 years ago, when it was a controversy in our household about whether our teenage daughters should get the HPV vaccine. And now there's so much research that shows that not only should they have gotten it, which they did, but every young man should be getting it also. And then the impact, so 92% reduction of that kind of cancer if you get the vaccine in place. It's just really, really good stuff. And then, if you haven't read Nicholas Taubman's The Case Against Sugar, it's really important because it's remarkable how much, not just obesity and its impact on cancer, but just sugar itself. One of the really interesting early things is they talk about breast cancer cells in a Petri dish, and you add sugar and they explode. They just grow so much more faster than before. So there's so much good stuff going on in the world right now that I'm really grateful for your leadership. I won't get in the way of your lunch. Bill, thank you for constantly putting this on, and for Donna. And since, was it 1 in 4 of us in the course of our lifetimes may be affected by a cancer? And so virtually every family, what you do right now affects us all in a very positive way. So thank you very much for all of us.
And thank you, Don, because the work that you do at the congressional level is really important, so I appreciate it. Thank you for coming.
Thanks for doing this, Don. I appreciate everything you do so much. So this was on. Good thing I wasn't whispering something. We're gonna start lunch, and we're gonna move through it slowly. So what I'd like to do, if it's okay, is maybe start with this end of the room here and just go through, grab a sandwich, and return to your seat. If you need to run to the restroom or stretch, that's great as well. We'll be starting up in about 15 minutes again, but if you can help yourselves. If you have any questions or you need anything, please reach out to somebody that looks like me, if not me. And then we'll move the rest of the room through. But if you could move through, get your sandwich, and then we'll sit down again. Thank you. Okay, something to eat. Did everybody get something to eat? Everybody? Who checked out those cookies that I probably shouldn't be serving? But they're good, right? Good. They got the cookie thing down. So we are now moving into the afternoon section of the workshop. And I would like to bring up Mindy Mesmer, who has been a speaker for us for a few years, because I would like her to introduce our next speaker and legislator, Representative Dan Kildee. And I'm going to turn the microphone over to Mindy. For some of you who don't know Mindy in the room, she has turned the state of New Hampshire upside down. She goes to war fighting for her kids and for other kids and for people like our friend Doris out there who have been working on the PFAS issue and several other issues. And so we're grateful to have you here today, Mindy, and I'm going to turn this over to you for Dan. Thanks.
Thank you very much. I'm honored to be able to introduce, thank you. I'm honored to be able to introduce Representative Dan Kildee of Michigan. I became familiar with his work a few years ago when I was asked to help out analyze what's going on at one of our bases in the state of Michigan that it's called Wurtsmith Base. And there I became aware of a very significant issue with contamination associated with these PFAS compounds, which is the subject of the Dark Waters trailer we saw earlier today in Rob Balot's work, who's one of the board members of Less Cancer. And Representative Kildee, I'm so thankful for the work he's doing on Capitol Hill for all of us introducing important legislation to address these issues and fighting the good fight, even though there's not a lot we're able to get done sometimes. It's very frustrating, but he has definitely been on the forefront of this issue, protecting our drinking water and pushing forth work in the PFAS task force that was formed in Congress. And I'd like to welcome him to the stage today. Thank you.
Well, thank you for inviting me to be here. And yeah, this works better for me, just in case I go rogue. You never know. No one's safe out there. But I want to thank Mindy for that introduction, but for all of her work. It seems like everywhere I show up to work on issues regarding PFAS, Mindy's there. And that's what it's going to take. Obviously, people like her who, been a real champion on this long before anybody even knew how to spell PFAS. So I came to this issue because of a contamination in my own home district. And just to give it a bit of context, I was elected to Congress in 2012. I am a child of Flint, Michigan, born and raised in Flint. Graduated from high school there. Actually got elected to public office when I was 18 years old in Flint, Michigan, more than a decade ago. Just want to see if you're listening. 43 years ago to the school board there. So Flint is in my DNA, and I came to understand exactly the threat that communities face around drinking water, something that we all almost naturally take for granted as being safe, with the Flint water crisis. And that's where I got to know one of the individuals associated with this organization, Dr. Mona Hanna-Attisha. She and I worked together on the Flint water crisis from the very beginning. And it was her groundbreaking work on blood samples of children in Flint that really blew the cover off that crisis. Little did I know that that would not be the only drinking water crisis that I would face, nor did I really understand fully that drinking water and water generally is a crisis in this country that most people don't even know exists. One of the threats was the threat that was the second crisis to come to me, and it was the contamination of drinking water, groundwater, surface water in Oscoda, Michigan, a small town at the very northern tip of my district, 120 miles away from Flint. But it's a community that hosted the Wurtsmith Air Force Base, as Mindy mentioned, a base that closed more than a quarter of a century ago, but still lives with the legacy of having hosted that base. PFAS chemicals are used in lots of different applications. Some of you may be familiar with it. But it's a chemical compound that's highly durable and is used in waterproofing, fireproofing, lots of other manufacturing applications. And what we know, sadly, is that it's ubiquitous in the environment. We are very familiar with its use on military bases because it's used in firefighting foam. And that's what happened in Ascota. With continued training for fires on the base and an actual fire in one case, lots of PFAS was sprayed through foam on the ground and leached into the groundwater and came to us because it contaminated the drinking water of people who were living in Ascota and depending on well water. And so we felt like, well, we got to take this on. And we didn't, at that point, see it as anything much beyond sort of the typical work we do advocating for a community that I represent. We didn't see it in its larger context until about a day after getting into this and realizing this is huge. This is potentially a huge problem. So these forever chemicals are everywhere. There are about 400 military sites that we know PFAS has likely led to significant contamination of surface water, groundwater, and potentially drinking water. But innumerable private sites where PFAS is likely contaminating people who don't even know it. It's interesting because in Michigan, if you look at, you can go to some of the sites, some of the advocacy organizations and others that are working on PFAS issues. You can look at a map, a scattershot map of sites where we know we have PFAS. You'll see a bunch of them concentrated in New Hampshire. You'll see a bunch of them concentrated in Michigan. And you would think, my gosh, what's going on in Michigan? I'll tell you what's going on in Michigan. We're looking for it. And that's why we're finding it. We don't have any greater prevalence of PFAS, likely, than just about any other place in the country that has a legacy of either military bases or industry or some combination thereof. So it's everywhere, and it's really dangerous stuff. Another one of your associates, I think a board member, is Rob Ballat. In fact, I see Rob's book. We were just chatting about that. Rob is one of the real champions, representing the people of Parkersburg, which was like really the biggest first massive contamination that was well understood. Rob went to bat for those folks and took on the chemical polluters, ended up in an interesting resolution settlement with DuPont, where the settlement essentially said, we're going to dig deep on this. It's not just going to be a monetary settlement. We're going to dig deep on this and find out what the effect of PFAS really is on human health. One of the most, maybe the most exhaustive human health studies ever done. 68,000 people participating in this study led to the conclusion, which ought to have been, the hypothesis, that these dangerous chemicals that are so resistant that they can withstand incredibly high heat, that they're not good for people to consume. And while these sort of anecdotes of terrible disease in Parkersburg were obvious, the data that C8 study ended up demonstrating shows that there are lots of threats to human health that PFAS represents, including cancer, and that's where you all come in, and that's why it's so important that we have this conversation. So, as Mindy said, we started off, you know how these things work, we started off just screaming into the wind on this. Nobody even knew anything about this. I would go to members of Congress and ask them about PFAS, and they'd look at me like I had three heads. And this was only a year ago when we launched this bipartisan PFAS task force. We put out the call anybody who is dealing with PFAS contamination, join this bipartisan effort. And in the first month, we were thrilled that 15 members of Congress came forward. I mean, we didn't know what we would get, but 15 members came forward. Now we have over 50. Why is that? Because of the actions of organizations like this one. The thing that will make the difference on PFAS, that will get us the policy tools to protect people from it, to require cleanup, the difference is going to be public awareness. Public sentiment's everything, as Speaker Pelosi often quotes Abraham Lincoln as having said. With it, you can accomplish almost anything. Without it, almost nothing. The way that we've been able to get momentum, modest momentum so far, admittedly, around dealing with this really significant environmental threat is because more and more people in states like New Hampshire, like Michigan, and other places are becoming aware that it's there. We don't need to do much more than educate people about the threat to their lives and to their children. They will take advocacy seriously when they know that this threat is real. So that's our job. That's our responsibility. That's sort of on us. And it's starting to bear some fruit. I'll just mention a couple things. So this PFAS task force, we had, just about every year, pass something called the Defense Authorization Act. It's the bill that authorizes and funds the U.S. military. And because the U.S. military is the biggest known specific polluter, this was an ideal place for us to put some PFAS legislation. And so the group of us that have been working on this had all sorts of bills that we were able to get onto the House version of the Defense Act. This is a little bit wonky, but it's really important to know how this stuff is going to play out. The House version of the defense bill included a lot of really good PFAS provisions. Some of the stuff that I had written and introduced as separate bills, but critically, one that would require the EPA to develop and enforce a drinking water standard based on science, which we don't have. We have a health advisory that says this really dangerous stuff, whose threat is measured in the parts per trillion, is not regulated in drinking water. We said in the defense bill it has to be. And then also categorized a couple of the specific compounds, more prevalent compounds, under CERCLA to require, or to give us the tools to require polluters to clean up the mess that they've made. Two really important pieces. We're celebrating, taking a little bit of a high-five victory lap as we pass this bill through the House. And like most good ideas, when it went over to the Senate, which is where good ideas go to die. Yeah, I'm a Democrat. The Republicans are our adversaries. The Senate is the enemy. If only it weren't true. I mean, sorry, senators. We have some great allies in the Senate, but not enough. And so they left some of the provisions in. Like I have a provision that requires the U.S. Geological Survey to go out and find all these private sites where we might see PFAS contamination, because the military sites are just scratching the surface. All those other sites are really important. But we need to know where they are in order to deal with the threat. And there were a few other pieces. Quicker phase out of the use of PFAS in firefighting foam, and a whole series of things. But the two really transformational pieces that we wanted to have in were removed by the Senate. And then in the process of negotiating a House and Senate compromise, the Senate prevailed. And we didn't get those two pieces in. We then went to the House, passed a comprehensive PFAS bill. It doesn't get us everything we want, but included those two essential elements and others. It's the PFAS Action Act that passed the House, but that's like a get well card. It doesn't really get anybody the help they need. It expresses our sentiments about PFAS. What we need is the Blue Cross card. We need something that can actually get us the care and the treatment that we need. And so the struggle in the next several months is going to be to revisit the question that we failed to succeed on in the last defense bill and either get it in a spending bill or the next defense bill or some other piece of legislation that's going to the president's desk. Interestingly enough, and you know, no sense being coy about it, the president's not with us on this and has been really antagonistic toward the issue of PFAS. You can ask yourselves why, but this town is usually a battle of interests. So figure out which interests benefit from us not regulating PFAS, and you answer all the questions that you need to pose. We need to overwhelm that. And whether it is the fight for clean drinking water or against thyroid disease or birth defects or cancer, if we don't deal with the environmental threats that cause those diseases, that cause those conditions, our job is made harder, your job is made harder. We're all in the same battle. We're all in the same fight. This is not about a chemical. This is about human beings. So, excuse me, that's where we stand. And that's where I think your voices can really make a difference because, like I said, and I'll finish with this, and then if there's a question or two, I'll take them. The only way we've ever been able to do anything in this town or in any other democratic forum is by mobilizing public sentiment and moving beyond whatever the particular argument is that might move me to act. Because if I'm, you know, people just think of me as like the drinking water guy. I mean, if you got to be a guy. Clean drinking water is not a bad handle. But if you are the cancer prevention person, this is your fight, you know? If you're the environmental justice advocate, this is your fight. If you're about the sustainable development fight to keep us from moving away from where we've already built and contaminated into other spaces, this is your fight. So let's argue with those who are in the way, not based on, you know, what was the initial question, and that is the Defense Department contaminating drinking water, but let's talk about it in the context of the things that go well beyond typical partisan or ideological divides. And cancer is one of those things. It touches everybody. It touches everybody without warning, and we all have an obligation to do everything we can to prevent it. And dealing with this terrible threat would be a really big step forward. So, thank you.
Go ahead, Mindy.
Yes, Mindy.
More important than actually charging EPA right now is coming up with enforceable limits, which I'm afraid to hear what they'll say right now.
Yeah.
It is to designate the compounds as hazardous waste
Right.
so that the Department of Defense will take this seriously. As you know, as we've seen in Michigan and New Hampshire, the Air Force has basically not accepted their responsibility because of how to. Are there plans now to continue that fight to get it listed as hazardous waste?
There are. In fact, that's one of the provisions that we want to try to work into either the next defense bill or another must-pass bill. I mean, passing these bills through the House with the current configuration we have in the Senate means it's unlikely that as a standalone we're going to get these bills through. But I think we made a good case, even though it didn't come to fruition. By the time we were done with the Defense Authorization Act negotiations, some of the people who should have been stronger allies at the outset in the House and stood stronger and fought harder came to understand exactly how significant this threat is. This is where information is really powerful. And like your voices would really be powerful the next time we go through this. You know, it is true. The one thing that we can't let the administration off the hook. Because right now, the Defense Department has it completely within its authority to pursue really aggressive cleanup of the contamination that they're responsible for. There's nothing that prevents them from initiating cleanup and coming to us. In fact, at one point in time, about a year ago, we were working to get more money in the appropriations bills for cleanup, And the appropriators went to the Air Force and they said, well, we really don't need it. We were ready to give them money. They didn't even want it. That has to change. And then, frankly, the Environmental Protection Agency has it within its authority to bring forward a drinking water standard. They keep talking about it, but talk is cheap, especially where I come from. I think we ought to have an agency whose task is to be a protector of the environment, like maybe an environmental protection agency.
Good idea. Good
Yeah.
idea.
Anyway, unless there's one quick one, I know you got a lot of other stuff to get to. All right. Thank you all. Thank you very much.
With the board members, can we, and Missy, where's Missy? Okay. We'll just come over here quickly and do it. Jan, you want to get in? Tom and Donna? Yeah. So awesome. That's why I said something. I don't know about that, right? Yes, right? Where is Dr. Carney? We're about to, if everybody can take their seats. Are we good, Andrea? I'm good. Come up here. So, can you take your seats, everybody? Thank you. Thanks so much. Thank you, everybody. Okay, with me is Dr. Jan Carney, who's from the University of Vermont. She is a public health guru. She's written a few books on public health. Go ahead, I'm sorry. Can we just have a brief break for Congresswoman Dean? Please. Sorry about that. Sorry, panelists. We have to catch these legislators while we can. We're so glad she's here. It's not rude. I'm Bill Cousins. Nice meeting you. I'm the founder of Less Cancer. Thank you. Do you want your microphone out here or back there?
Stand right there if I
Thank
could,
you
and
for
I'll hold
joining.
it. Oh my goodness.
I'm so grateful you're here.
I'm pleased to be here. I apologize. I think that was extraordinarily rude of me. But thank you for offering me this chance to speak very, very briefly. My name's Madeline Dean, and I'm running between Judiciary and Financial Services hearings. And I'm supposed to ask questions in about 3 minutes. But I wanted the chance to be here with you in this extraordinary organization, Less Cancer. Cancer has impacted my family, many, many members of my family. I'm not over the fact that my mother died of ovarian cancer in very rapid order. My uncle of bladder cancer, my good friend of lung cancer, my other good friend of lung cancer, not even being a smoker. So I've got cancer on my mind. But I'll focus on another area, and it has to do with PFAS. So I'll acknowledge real quickly, I don't know if I see Rokana here. Rep. Kildee, I did see you. Hello, Dan, for your leadership. Michigan Governor Gretchen Whitmer, I understand, is Skyping in later. and I see you have exposure. We had the opportunity to have Attorney Rob Bilott for a special screening of dark waters in my district, because my district has the PFAS water contamination issue in it, stemming from Willow Grove Naval Air Base, the legacy of firefighting foam that is from there. Pardon my voice, I don't always sound like this. So I want to thank Less Cancer's founder, Bill Cousins, for your dedicated work, extraordinary dedicated work on preventative cancer programs. Is Mindy Mismer here? Where's Mindy? She was here. Mindy is a friend and has helped me in my area. There's Mindy. Hello, Mindy. How are you? Good to see you. Former New Hampshire representative, scientist, advocate, leader, and you've taught me so much, dedicated fighter in the battle to rid our communities of the forever chemical PFAS. Thank you for joining me in my district on that issue, and I need your continued support and leadership and smarts on it. And New Hampshire is a great example of how we can approach PFAS water contamination. The contaminant exists on more than 400 military bases nationwide, as we all know. It is in 48 states. I'm sure it must be in those other 2. They just haven't identified it yet. And it threatens the health and safety of those who live nearby. We see these cases in my area. We just met a gentleman who is a father of 2 young daughters. He and his wife have both had cancers. They are right abutting the Willow Grove Naval Air Base. And he said, I wish I had grandchildren, but both of my daughters in their 20s had to have hysterectomies because of the threat of cancer. This is very real in our communities, and people for decades have been telling us so. The EPA website describes the effects, low infant birth weights, effects on the immune system, and cancer, and yet we still haven't called this a contaminant, a toxin, as we should. Over the last year, there is some light, some hope. In my very district, we got a $1 million health study for Montgomery County, one of only 7 in the country. It's only a small start, but it's an important start. We also just got released $2.8 million from the Air Force to stop the ongoing contamination. Maddening to me is that there is ongoing contamination off this base, literally directly into a state park. It's sickening. I've been on the base twice after a heavy rain the previous day, and you can see the ground surface water flying into a state park pond that the state actually stocks with fish. And it is PFAS contaminated water. So we did get $2.8 million for a retention and filtration, permanent retention and filtration system at that ongoing outlet. The fight continues. We must address this challenge with a national solution, which means that listing, number 1, PFAS as a toxin, banning its manufacture, regulating its disposal, cleaning up our water supplies, and providing health testing and treatment to everyone who needs it. As we connect all this back to cancer, I like to go back to Pennsylvania's Constitution. Article 1, Section 27 says, we, the people, have the right to clean air, clean water, and the preservation of our natural aesthetic, not just for us, but for generations to come, like my 3 grandchildren. And of course, all of that connects to our health, our public health, and the reduction and someday the elimination of cancers. Thank you again, Mr. Cousins. I apologize for interrupting.
No, we're going to get the, can we take a quick picture, board members, with Congresswoman Dean? Thanks for your help. I appreciate that. I appreciate your voice. Please come on. No, we appreciate everything you're doing. Over here, Miles. No, you're not. We appreciate it. We make way for that person in the front. Thank you. Jan Carney, let's try this again. One of the things about this workshop is you have to be especially flexible because we want these people's voices to be part of this programming. Here we have Dr. Carney from the University of Vermont. She's with the medical school. We've done projects with her. We have worked together for several years. She's helped guide me and the organization on public health science. I'm going to turn this over quickly to you. So grateful for everything you do.
Thank you very much.
Thank you.
All right, I'm going to have my panelists come right up.
And you want to talk about healthy city. Do you want the podium? And that mic? We can fix it so you can have that mic?
Let's see.
Everybody's got their own.
I think I'm good.
Are you
Either,
good?
yeah, this will be fine.
Drifted off.
So this is the Healthy Town, Traverse, Michigan.
Traverse City, Michigan.
Traverse City, Michigan. Excuse me. And prevention is our future. And I want you to hear from each of our panelists for a little bit about what they actually have done and what they're going to be doing. And then I would invite all the students, this is kind of a dangerous sleepy time after lunch, to be thinking about one question from each of your table because I think we'll have time and look forward to your questions. All right, let's see. First, let's start with, where is Kathleen? Ah, there you are. Kathleen Larea? Larea. Welcome. And Kathleen is the Executive Director of Munson Healthcare Oncology Service in Traverse City, Michigan. And she earned her Bachelor of Science in Occupational Therapy from Wayne State in Detroit and a Master of Science in Health Service Administration from Central Michigan University in Mount Pleasant, Michigan. She is responsible for building an integrated network of cancer care within the Munson Healthcare Organization. So, my first question for you is the cancer burden in northern Michigan is high. 4 of the 5 counties with the highest risks are within the community served by your healthcare system and family cancer center. So could you tell us a little bit about what you're doing to reduce this risk?
Yeah, so we're rural healthcare, as Kelly had talked about earlier. So we service 30 counties, so northern Michigan and then part of the eastern Upper Peninsula. And so as the cancer burden in the state of Michigan is analyzed, we discovered that the top 4 of 5 counties in the state of Michigan fall within our service area. And so why is that? And so we're so fortunate to have our researchers, community researchers in our program, so we're still looking at that. But our doctors and our administrators a few years ago decided that we had just sporadic treatment throughout all of these counties. And so we really wanted to create a hub and spoke model of care and developed a brand new cancer center that's been open 4 years. But my philosophy when I got there was I just didn't want to be the treatment center, that 42% of cancers are avoidable, preventable. So what could we do on the screening part, the prevention part, treatment, and then those that survive? So we've been partnering with a lot of integrative therapists within our city so that we can have symptom management for patients going through treatment. Some of our treatments are very toxic, and so they might get numbness and tingling, cancer fatigue. So what are we doing to help prevent that? But more importantly, we have health disparities in our communities that are typical. Smoking is very high, obesity is very high, and just having access to screening. So we've developed actually some funding to help support our population is either affluent or indigent. And so we've got that wide range there. But there are patients that have to travel over 100 miles to get care. So we have gas cards for folks. We have a Munson Manor that's a 30-bed facility where people can spend the night and have their treatments. And we just recently added 4 RV hookups for those that come with their RVs, and then their families can stay with them. So trying to look at just different ways to access, to have people have access to care. And then all of our little hospitals, so Munson's part of a 7-hospital system, which is a 400-bed big hospital in Traverse City. The rest of our hospitals are as small as 25 beds. And so we got all of those CAT scan machines to be certified to do low-dose CT scanning. So that's for patients or people 55 to 74, 30-pack smokers, or have quit in 15 years. We screened 4,800 patients and found 54 stage 0, stage 1 cancers. That's a very high rate, but stage 0, stage 1 can be curable. But what do you do if they're still smoking? There wasn't much smoking cessation, so we had to go around and develop facilitators to do smoking cessation as well. So that's a few things.
Thank you. I want you to, again, think of your questions. All right. Next, I'd like to introduce Ty Schmidt, who's is a master in physical therapy. Is that correct? All right. And who is the co-founder of Norte. Canadian import. Time came to Traverse City in 2006, along with his wife. They founded Norte in 2013 to advocate for more happy, healthy, strong young people. All right. My question to you is, how can we help prevent obesity, cancer, and other chronic conditions through exercise and organized activity in the community?
That's a great question, Jan. Yeah.
Because he wrote it.
Well, first, I just want to thank Bill I was here at this workshop 2 years ago, my third trip to DC 12 years ago. I was here with my dad at NIH, who passed away from melanoma, last-ditch effort. So it's trip 3 to DC. I'm proud to be up here on the Healthy Towns panel because I think a healthy nation is built on healthy towns. A nation with less cancer is built on towns with less cancer. So, as a physical therapist, physical activity, moving more, is a passion of mine. I spent 18 years in the PT clinic treating disease and dysfunction, and wondered if there's a better way, because once you make habits, they're really hard to break. And so my wife and I, who's also a physical therapist, got a little bit frustrated with our neighborhood schools wrapped in car lines, and did something about it. And so we were working hard to work on getting kids moving as part of ordinary life. Nothing against sport or recreation or exercise, but I believe if you walk and bike as part of ordinary life to the places you normally go, to school, to library, to the park, to your buddy's house, we all, all the benefits that come along with that are important. Just like Dr. Isaac speaks about healthy weight and obesity, this is what it's all about. And teaching kids early on when they're 3, 4, 5 years old that it's perfectly normal to walk a quarter mile to school, that it's healthy, to convince mom that it's safe and not dangerous. So that's what Norte is doing. We're just implementing a lot of evidence-based strategic work designed around people, specifically young people, who will then grow up to be adults, where moving, again, as part of ordinary life, is just normal. It's healthy, it's convenient. So Norte's work, although we're in a small town in Traverse City, we lots of inspiration going around the country. So, and I look over here at some of the high school students in Virginia, and I ask you about how accessible your school is. How accessible was your elementary school? Talk about, is there policies in place, whether it be at the school district or community district, where they make walking, biking easy, and again, normal, not putting barriers in place. And we think of it just as a simple thing that, well, kids are getting exercise, but the ripple effects that happen when we make it safe and convenient for kids to get to school ripple through the neighborhood, ripple through the town. And we know that adults who move more as part of ordinary life have a healthier weight, therefore less cancer. And I look forward to more questions.
All right. Thank you very much. All right, we'll go to this side of the table, and we'll go next to Kelly Herko, who is Dr. Kelly Herko, PhD, MPH, Assistant Professor, Department of Epidemiology and Biostatistics, College of Human Medicine at Michigan State University. And so my first question for you is, we heard a little bit about how the rates of cancer differ between rural and more urban areas. Can you talk a little bit more about that and some of the preventive strategies we might consider in that challenging rural environment?
Sure. So cancer rates associated with modifiable risk factors like tobacco use and HPV and preventive screening services for colorectal cancer and cervical cancer, those cancer rates are higher in rural areas. So the role of preventive services can make a huge impact in reducing rural cancer disparities. Some of the national data suggests that cancer mortality rates in rural areas are 10% higher than urban areas. So we can't just focus on the preventive piece, but also think about secondary prevention, as I call it. So what you can do to prevent recurrence after you are diagnosed and improve your long-term prognosis. I kind of talked earlier about all of the factors that contribute to this, and rural areas are particularly susceptible, higher rates of poverty, lower educational attainment, an older population, and then a lack of healthcare access, and that's a really critical issue that potentially broadband internet and telehealth can address. Some of the challenges, though, with studying rural cancer disparities, most of the academic institutions are located in urban settings, and there's not as many researchers based in rural settings. So I feel very lucky that as this model from Michigan State to place researchers in the community, I don't have to necessarily work to create relationships within the community because I'm there full time and I understand the issues that are affecting our patient population. As Kathy mentioned, we have people traveling over 100 miles each way to get their cancer care. And so we need to think of unique solutions. We can't just take what's worked in the academic centers in urban areas and translate them here. The other thing I want to point out is that of the portfolio for NCI, for National Cancer Institute's funding, only 3% from the last 5 years went to rural cancer projects. So we really need more funding in this area. And it's more of concern with the new budget for 2020, where NCI took an $897 million cut. So funding for any cancer research is really getting hit, and we don't have enough to really make progress in this area.
Thank you. Thank you very much. Last but not least, My Stanley, Communications and Marketing Manager, Traverse Health Clinic. And let's see, my first question for you is, as a community health center, in what ways is Traverse Health Clinic working to engage its community that go beyond providing direct healthcare services?
So we really try to think about the community in our community health center. And so we want to engage our patient population in efforts where they can take some agency over the things that affect policy that impact their lives directly. Next week, the League of Women Voters is doing a voter registration drive at our clinic for our patients. We recently received a grant to help with census engagement and education for our patient population. So as an FQHC, 51% of our board is made up of patients. And last summer, one of our patient board members said, what are you going to do to make sure that the people who come to this clinic know about the census, understand its importance and impact, and complete it? And for the first time, the census is going to be, their goal is to have 95% of the census completed online. Well, broadband internet access is an issue. A lot of the households in our area do not have it. So another option is the phone. Well, how many people still have a landline? If you have a cell phone that has a plan with minutes, you run out of minutes every month, you're not going to stay on the phone to complete the census. So, those are some high-level things. But then in terms of what we do with our patients, we provide transportation assistance, gas cards, bus passes. We work directly with our local bus provider, Beta. When we first moved into our facility, the bus stop was across a busy 5-lane street. There was a crosswalk that ended in an earth berm. There was no sidewalk. So we reached out to Beta and asked them if they could move that bus stop directly into our parking lot, because so many of our patients rely on public transportation, and they did that for us. We really are trying to remove obstacles to care as much as we possibly can. We also, one of the really exciting things that we've been part of for the last 3 years is a fruit and vegetable prescription program, and that's a partnership with an organization called Shape Up North and the Michigan State Extension. And that program allowed people who had a chronic health condition and another factor that put them at risk to attend either cooking classes or education sessions that were put on at farmers markets, and they could earn up to $100 in tokens to be redeemed for fruits, vegetables, fresh foods, but also seedlings so that they could plant and grow their own produce. And this program has been really, has had a huge impact on people's comfort with shopping at a farmer's market, which can be a little bit intimidating if you've never been, and it can be, frankly, be a fairly affluent group of people who tend to shop there. And it also improved the amount of fruits and vegetables that they were eating on a regular basis. And if you think about it, if you've only really encountered grocery store produce or canned produce or frozen produce, if you don't know what to do with kale, if you see it and you know it's good for you, you're not going to bring it home. And so having those cooking classes so people could learn how to actually prepare those healthy foods in their own homes, that was a huge piece of that program. And we're excited to be part of that again this year once it gets to be spring and summer.
Thank you. I think if it's okay with you, I'd like to open up to some questions. Right here, could you just tell us your name and where you're from?
Okay, so my name is Casey, and I'm from Monticello High School in Charlottesville, Virginia. So my question is for Ty. So you were talking about like walking to school and stuff like that. So I live out of district from Monticello. I applied to the HMSA Academy. So it's 30 plus minutes to get to school for me. So how would like walking to school, like you were talking about policies and stuff like that. So like what would
That's a good question, Casey. And I think there's, with open enrollment and school of choice, not all kids live within a half mile of their school anymore, and we get that. But it's really thinking about how can we make part of the trip, and I don't know whether you bus or then walk or how you get to school, but we want to provide solutions for the majority, right? And so we think neighborhood schools are important. We know that kids arrive from all over the place, but in this culture where movement is basically stripped out of our day-to-day lives now, where we sit more, we screen more, there's an opportunity to at least think about how can we empower kids to learn the skills, because it's more than just getting themselves to school, right? They're going to grow up. They understand that they have independence with mobility. Their mom's not just an Uber driver. They don't need to be delivered like a FedEx package from here to there. So it's not just about getting to school. It's what that leads to down the road.
Great. Thank you. Yes, please.
I have a question for you. Our demographics, we live in suburbia, Northern Virginia. Most of us live in, large plots of land, 100 acres plus, a lot of us do. What are the cancer rates? I've heard a lot of talk about urban and rural, but what about suburbia?
Yeah, that's a good question. So one of the things that I'm currently working on is trying to understand heterogeneity in cancer rates within both rural and urban settings. It's really difficult to define rurality, especially when you're thinking about what are those drivers of the disparities. There are over 15 federal definitions that are currently used to define rural areas. And one of the current pushes, at least from the NCI, is to use more of a continuum. So there's something called the Beal codes, the rural urban continuum codes. And so there you can piece out those suburban areas. So it's a coding system from 1 to 9 that goes from more urban to more rural. And so I'm currently working with a group from the Society for Behavioral Medicine to look at how those codes impact health behaviors. And that way we can provide more targeted interventions. So for example, in our region, as Kathy alluded to, we really have a bimodal income distribution. We have a lot of people on the higher end, but we have a lot of people on the lower end. We don't have as many people in the middle, but we're all considered rural. And our region is very large. And so we can get some funding for the rural settings, but it might be targeted in Traverse City where it's not as needed as it would be 20 miles outside of Traverse City where the main hospital is, where it's even more rural. But right now, because we usually rely on the rural-urban dichotomy, we're not targeting those areas. And so I think using more of a granular approach in thinking of the rural-urban continuum instead of focusing on the rural-urban dichotomy is going to be important so that we understand the suburban, the different levels of urban and rural, and that will inform our understanding of the determinants of disparities as well. So it's work in progress.
Can I add to that?
Please.
I guess I would just add another component to that, and it's about screening, whether you're in a rural community or an urban or suburban area. I came from the Detroit area, And our African American female population were dying of breast cancer at a higher rate than the nation. And we developed a mobile mammography unit to bring into the city. And I still couldn't get people to use that because there was a fear factor. So there's also that behavioral component of how do you reduce that fear to get screened so that then we can find out. So whether you live in an area that has higher risk or not, it's still trying to get people to have the mammographies that they need, the colonoscopies that they need, the lung cancer screenings that they need.
Thank you. Please.
Okay, so in thinking about the fact that exercise is an important factor in cancer prevention, and talking about, for example, rural schools where there's really not an opportunity to walk to school because it's fields and no sidewalks, and then in addition you have an education system that's taking minutes away, it seems, each school year from the time that elementary children are allowed to have recess or even PE classes. So what types of public policy things are being done to address exercise at that level, kind of when kids are still young, and what is it that citizens can do to help reverse that trend?
Yeah. So we partner with 31 area schools, many of which are rural. And just because they're rural, obviously there's challenges, but it's, again, not impossible. And we don't expect any kids to hop on the the county highway and walk 14 miles to school. But again, school-based programs, talking about mobility, independence, the skills, and you ask about policies, there's wonderful policies happening across the U.S. You just go to Safe Routes Partnership. There's all of these policies that are easy to hard in implementing because you're right, PE is being stripped, recess time being stripped, teachers have a million things on their plate, principals don't have time for it, and I'm just an ordinary dad citizen who saw something and offered to help. And I think like that's what each single one of us can do, whether they're a parent or an alumni. What can I do to help? Talk about access, talk about connection. Same thing with PE teachers. We make friends with the principals first and the PE teachers second, and because they believe it and they understand like these skills. Nothing against baseball and soccer, but mobility skills where they learn that it's normal to get themselves to the places they need to go transfers to adulthood. We know that. And I will just give a plug to the CDC, just came out with this really cool active people, healthy nation, 8 strategic steps to integrate movement. And I would just really quick, Casey, Google CDC, active people, healthy nation.
Thank you. Thank you. Yes.
With the cooking program, it does seem like a really great solution to that problem. However, I know that this is the first time I've heard of it. What are you doing to branch out, and what, I guess, places are you oriented and reaching through this program?
So, to be perfectly honest, the program in Traverse City is modeled on a program in Washtenaw County, which is Ann Arbor, U of M area. So this was something that we saw and our community saw that was successful elsewhere and moved it up to our setting. And so our health clinic is one of 3 primary care providers in our area that is reaching out to our patients with this program. I would love to see there be more mobile farmers markets. I know Benzie County, which is just outside of our area, just to our west, actually has a mobile farmers market that goes around and really the idea is to meet people where they are and bring that to them. The challenge with the program for a lot of our patients, since I think earlier I talked about the neighborhood that we're in, technically, we have 2 sites for the farmers market in Traverse City. They're both, quote unquote, across town. Traverse City's not a very big place, but psychologically, there is a challenge for getting people to go from where they live and where our clinic is to those locations. And there's also issues with mobility, but we do have a good public transportation system. Norte is doing a great job about making our city more walkable and bikeable for everyone. And so that's a great thing, but that is something to consider, that where are the farmers markets happening relative to where the people who are being outreached to live, and how to bridge that gap. So that's a great question. Thank you.
go right here first.
It really is great work that you guys do in Traverse City, but how can we like look at that in a macro level and bring the research and findings that are happening there to a national scale, and what can students and people across the country do to help you guys in that effort?
You know, I just want to make a comment about obesity and just healthy eating. And so we experimented with a program at Munson Hospital because unfortunately, many of our healthcare workers are obese as well. And they work 24-hour shifts and they don't have access to good nutrition food. So we started a traffic light program so that at least when you're scanning the cafeteria or when you're hungry, you can have the red, yellow, and green dots. And so you kind of know that if I grab that red dot choice, it's probably not my first best choice. And so now we're trying to partner with our schools to have better foods in the schools, but then to have that red, green, yellow dot system as well. And that you can even do that in your own home and challenge your siblings, you know, and what your choices are to eat or your buddies.
I'll just say there's a whole area of research now on dissemination and implementation science. And what that is trying to do is to take these evidence-based strategies that we know work. There are so many resources out there that have been tested and shown to be effective, but they're not put into clinical practice. And so that's a whole science to understand how to best implement them, but there are a lot of resources that you can find. And I think as a group, you know, in Traverse City, we should focus on how we disseminate the results of our programs, because getting those evidence-based strategies out there can then be used to test the implementation on a broader scale. And part of that needs to be tailored, because you can't just take what works here and think it's going to work in your community. You have to engage the stakeholders in the local environment to understand the barriers to that strategy in that region.
Thank you. Right here. Oh, I'll come back.
My question kind of goes a little bit off of the last question. It seems like in Traverse City, these programs have been so widely successful. And I'm wondering if there's something that you attribute that to specifically in your own community that might make the programs that you created more successful than on a macro level nationwide. You were a little bit saying how it would have to be tailored to different communities, but do you see something specifically in your community or some part of that that could be expanded, or how, and also where are you guys getting the funding for this? That's another big question that I had.
Who wants to try that one?
I'll tackle it a
All
little
right,
bit.
go for it.
Traverse City is a cool town, but there's nothing special about Traverse City, and nothing what we've done, I believe, can't be replicated elsewhere. When you engage and you inspire people who care, including young people. So Norte has a youth leadership council, and just to your point, I mean, I think we need to listen to our young people, give them a stage to talk on. There's nothing more powerful than a young person getting up at a city commission meeting and making the case for their school to be more accessible, connected, talk about equity and transportation, and that link to health. So we base all of our stuff, again, on science and evidence and what works. We're also not afraid to try things and experiment and look for things and pivot to what works, because although, again, every town is unique and different. So whatever works for your town, my only advice is to do something and to try something.
Regarding the funding part, I'll just speak to the food prescription program, because Munson Healthcare and Priority Health, which is an insurance payer in the state of Michigan, they partner together to try and put forth some of that. So some of the health insurance plans are obligated to do some community work, and that might be a place to tackle.
I think also, you know, you can link priorities. So, for instance, myself and the other epidemiologist who's based at Munson Medical Center in Traverse City realized that hospital readmissions were a huge issue, and that's not a unique problem to Traverse City, that's nationwide, and hospitals are now getting dinged by Medicare and Medicaid. A lot of money is being spent to try to avoid these readmissions, and so working with my partner, we were able to get a grant to look at food as medicine and how we could deliver nutritional services after patients left the hospital to see if that reduced hospital readmissions. So if that we can show that that program, and we link these patients to Meals on Wheels, existing community programs after our initial medically tailored meals are delivered, if that program is cost effective, then it could be sustainable because the hospital was already spending money on these readmissions.
I think Ty had a question here in the back. Not Ty, but that's Tim. Did you have a question, Tim? Okay, good. Okay. I did want to jump in on what Ty was saying because I was thinking about Ty and looking at Tim one of those days. And, you know, Ty says, yeah, if I can do it, we can do it, you can do it. Me, I just want to back up a little bit. These people are extraordinary, and they have been dealing with some very serious public health issues in Traverse City. While we hear about tourism and affluence, we also know that they deal with some very cataclysmic public health issues. And that's why this year Less Cancer called them Healthy Town Traverse City, because they've done extraordinary things to turn Traverse City around. And so we're not starting out with a community that's got it all buckled up. And they've done great work. And I just wanted to jump in on that before I let it go. You might want to wrap this up because we're running a little behind. Thank you.
All right, then. I think that I want to thank our panel.
Thank you.
Okay. I want to give you pens. Does everybody here? Got a pen? There are a couple repeats here. We can just get up here and do. I hear Ty. Did you get one? I'm
so sorry. I want my pin.
Guys, if we can get board members up here with this panel. Quickly, board members that are here, Miles, O'Brien, and Donna, and are we all in here? Everybody in here? Miles, are you in? Miles? Now the sling of feeding peas is like killing us, right, Missy? Yeah, it's killing Missy. Sure. Thank you, everybody. Thank you. Thank you, guys. Traverse City, you're doing amazing things. So, Jan Carney, we're going to talk about your student, and I'm going to let you turn this back over to you.
Okay, great. One of the things that we do in my role as Associate Dean for Public Health and Health Policy and Professor of Medicine at the Larner College of Medicine at the University of Vermont is we really believe in educating our medical students in public health so that they see their patients outside of hospital and clinic settings and understand our communities, neighborhoods, and that there are many factors that determine people's health. Part of that, all of our second-year students in groups of 6 or 7 do a community-initiated public health project, and we have 17 projects each fall. We have amazing projects from our students, and I am so incredibly proud of them. One of our students is here today to talk about their project on HPV and cancer prevention. So I'd like to introduce Rachel Matter, who is a class of 2022, to talk about her public health project. You can use the podium or the yeah, go ahead.
Hi, Dr. Hi, everybody. Thank you, Dr. Carney, for the introduction. I'm gonna move this. I'm so excited to be here today to talk to you guys about the important topic of cancer prevention. My name is Rachel Mathur. I am a second-year medical student, almost third-year medical student at the University of Vermont Larner College of Medicine. And as Dr. Carney explained, as part of our second-year curriculum, we work in small groups on a public health project and partner with community agencies. Our group was lucky enough to get to work with Bill Cousins and Less Cancer, with Dr. Carney as our faculty mentor. Our group decided to explore knowledge gaps regarding human papillomavirus, or HPV, an infection that is responsible for nearly 35,000 cancers annually just within the United States, including cervical, vulvar, vaginal, penile, anal and oropharyngeal or head and neck cancer. HPV also has a vaccination that can prevent over 90% of these cancers. But despite this, there's low uptake among US adolescents, and we wanted to know why. Previous research shows that the low uptake is largely due to a lack of knowledge regarding the virus, its consequences, and its preventability. Historically, HPV and its vaccination have been associated with females and sexual activity, and this association is still pervasive today. Many people do not know that HPV can cause cancer, that these cancers can affect both males and females, and that the vaccination can be given to and benefit both males and females. There's even some evidence that healthcare providers are not aware of the association between HPV and non-cervical cancers. Our group specifically wanted to evaluate knowledge gaps in a presumably well-informed and health-conscious population, the followers of Less Cancer. We designed a brief true or false survey and shared it to Less Cancer's website as well as their social media outlets. We also collected demographic information on age, gender, and geographic location. We received surveys from 200 respondents. Of this, almost 3/4 were women, 1/4 were men, and less than 5% were non-binary. 40% were between the ages of 18 to 45, and the rest were over 45 years old. 84% of respondents were within the United States from 38 different states. So what we found is that while 90% correctly answered that HPV can cause genital cancer and that the HPV vaccination can be beneficial for both males and females, only 80% knew that the vaccine is beneficial even after sexual activity. And perhaps most startling, only less than 50% correctly answered yes to HPV can cause head and neck cancers. There was no association between demographics and correct answers. Now, although this was just a pilot study, these results suggest a major knowledge gap. Further highlighting the importance of this, research shows that while cervical cancer rates have plateaued, oropharyngeal cancer rates are increasing. A 2016 study by the Center for Disease Control and Prevention, using population-level data, found that there are more annual cases of HPV-attributed oropharyngeal cancers than cervical cancers annually. Historically, oropharyngeal cancers have been tied to tobacco usage, but the study found that 70% of oropharyngeal cancers were likely attributed, at least in part, to HPV. Now, the vaccine prevents over 90% of HPV cancers, including oropharyngeal. But the CDC 2018 National Immunization Survey showed that only 51% of adolescents ages 13 to 17 have completed their vaccination series. So what do? Our group recommends that it's time to change the dialogue surrounding HPV and the vaccination. Rather than continuing to discuss it in the context of sexual activity or as a sexually transmitted infection, we propose that it is far more effective to focus on the vaccine as a form of primary cancer prevention. And HPV has come up a lot today in many different conversations, and I think more so throughout the day. And that's because it's an easily avoidable and preventable cause of cancer. This is a vaccination that can prevent cancer. And not just cervical and genital cancer, but also cancers of the head and neck. We encourage healthcare providers to emphasize the potential for cancer prevention, particularly oropharyngeal cancer. Research shows that the quality of physician recommendation, including specifically whether or not they discussed cancer prevention, is associated with uptake of the vaccine. We also recommend that education efforts and community organizations, including Less Cancer, place an additional and renewed emphasis on the aspect of cancer prevention and the HPV vaccine. The immune response to the vaccine is stronger the younger it is given, and is more beneficial if given before sexual activity, before there has been any exposure to HPV. So it is crucial to vaccinate adolescents early. And this doesn't mean that adolescents are going to be sexually active as soon as they're vaccinated. It just means that if and when they are sexually active, they will be protected against cancer. According to the latest CDC statistics, there are an average of 44,000 cancers per year in sites that HPV is often found. And of those, almost 80% are caused by HPV. Again, we're talking about nearly 35,000 cancers caused by a virus, and we have a vaccine that can prevent over 90% of them. It's time to change the dialogue around HPV and use the tools that we have to eradicate the tens of thousands of preventable HPV cancers. Thank you.
I lose this thing. I need a tile for this. Do you guys know what the tile is? My whole world's attached to a tile. Car keys, phone. Can we come over here and take pictures? If you, and I have a pin for you too as well with Dr. Carney. Yeah, right here. Yeah, it was great, Rachel. Super good. Thank you. TikTok. I'm the ringmaster. I quality control. All right. Thanks for everything. Thank you. That was great, Rachel. So I want to bring up Tom Yuldrick. And Tom is going to introduce Dr. Sasha Bute. It's taken me 3 years to learn his name. So I can finally say it. But you want to take this up there? And
Sure. So that was a very difficult act to follow. Rachel, congratulations. Congratulations on a really great project. I couldn't agree more with the need to change the dialogue. And thank you for finding gaps in the understanding of less cancer community of the totality of cancers that could be prevented. If just cervical cancer could be prevented with an HPV vaccine, that would be enough. But really, the scope of cancers that can be prevented by HPV is tremendous. So it's next my great pleasure to introduce my colleague, Vic Saharsabudi. I can't say it as well as Bill can. Vic is a program director at the Division of Cancer Prevention at the National Cancer Institute. He runs a large portfolio for HPV cancer prevention. His expertise in understanding the best way to use existing vaccines, ways to look at novel vaccines, ways to triage cervical cancer preventions, and how to do this not only in the US but around the world. So without further ado.
Thank you, Tom. So thanks, Tom, and thanks, Bill and Less Cancer for having me here. It's the third year in a row I'm coming here and talking about our work, primarily to talk about some of the work that NCI undertakes related to HPV and cervical cancer prevention, or broadly HPV-related cancer prevention. I think it was perfect timing for me to talk right after Rachel did fantastic talk and great survey, and thank you, Dr. Carney, for getting something like this started. I think it's a great opportunity to highlight some of the challenges related to uptake of HPV vaccines. As Rachel alluded to, this is one intervention that is older than the oldest iPhone. It's older than Twitter. It's older than Google Maps navigation. It is something that's available since 2006. Seems not too long ago, but it is older than all these inventions, and yet only half of all eligible children in the US get this vaccine, primarily because of so many misconceptions around what the vaccine causes, whether it would lead to increased sexual activity. And as Rachel said, there's so many misconceptions around the vaccine being labeled as a vaccine to prevent a sexually transmitted disease, that if we change the conversation and make it around cancer prevention, that changes the dialogue considerably with parents, with providers, that provider-parent communication. In fact, NCI has invested efforts and resources into learning what might be those improved approaches to increase provider-parent communication. And there are organizations like the CDC and the American Cancer Society who are also working on this through something called as the HPV Roundtable. You can check out that website. There are a lot of resources to look at what might be the facilitators for some of those conversations. But simply the spectrum of cancers that the vaccine can prevent. Cervical cancer, as you know, is one of the commonest HPV-related cancers globally. About 500,000 women get cervical cancer every year. 250,000 or more die due to that cancer. It's an entirely preventable cancer. The problem is it's not fully prevented, particularly in parts of the world where there is lack of access to resources and lack of trained manpower. What we are doing at the NCI is trying to find several innovative approaches to get over this gap. One of the things in relation to the HPV vaccine, what we are focused on is trying to see if reduced doses of the vaccine can be as beneficial. When the vaccine first came out in 2006, it was a 3-dose vaccine series. As a result of some of the efforts that NCI and other partners have undertaken over the years, It's now only a 2-dose vaccine series that's currently recommended for children under the age of 15. So if you're vaccinated before 15, you are only recommended to get 2 doses. If you're over 15 and up to the age of 26, you can get the full 3-dose series. But what we are now trying to do is trying to see if a single dose of the HPV vaccine may be as beneficial as the 2-dose series. And this is requiring to mount a very large clinical trial, which we are currently undertaking in the country of Costa Rica in partnership with the government out there to see if 1 versus 2 doses would work equally well. And we are going to study this in a large population of about 20,000 girls and boys and trying to see if they mount an immune response and have a benefit of the vaccine in terms of prevention of HPV infections per se that might lead to a change in the WHO and CDC recommendations around vaccine doses. But that might be a game changer because consider how many people can be vaccinated with double the dose that might be available if you change it to a single dose schedule. The other thing we are doing in the context of screening for cervical cancer or other anogenital cancer is looking at newer and improved approaches. One of the mainstays of screening has been pap smear screening. I don't know if this was talked about earlier, but pap smears are the frontline mode of cervical cancer secondary prevention in the US for several years, several decades. In fact, that has led to a decline in cervical cancer incidence rates over the last several years. But there are still challenges to uptake of pap smears, which is why 13,000 women continue to get cervical cancer in the US every year. I think every case of cervical cancer represents one of the greatest public health failures of our times because it is fully preventable, yet it is not still prevented. So what we are trying to do is trying to see what might be those barriers to uptake of pap smears. So we are recently launching a study called as Last Mile that will actually take a self-screening approach to HPV. We are going to use a simple home-based or a clinic-based swab that a woman can collect herself and then try to see if that swab is comparable to an HPV test collected in the clinic by the physician. And if that validation is done and the FDA approves that assay as an approach, it might suddenly open up an avenue for taking screening to the last bit of women who do not get screened, and therefore we get this totally unintended rate of 13,000 women getting cervical cancer every year. So in addition to that, we are also focused on a visual method of screening, particularly for low resource settings where there is no current good screening approach and trained people to do colposcopies or do cervical cancer diagnostics. So we're using machine learning or an AI-based approach to look at the cervix through a cell phone camera, through a screening approach done once, but eventually will replace the need for a highly trained physician or a gynecologist or a nurse practitioner for that matter. But AI can quickly give a diagnosis or at least a triage whether this should be referred or treated or can be sent home safely. So some of those aspects of clinical trials, clinical prevention research are what NCI is supporting through a range of colleagues across the world, including our good friend Tom Ulrich here. We are in fact working with Tom and colleagues in a new network focused on HIV infected or HIV positive people globally, particularly in the low and middle income countries of Latin America and the Caribbean region, where we have launched a new initiative focused on improving approaches to primary prevention, to secondary screening and triage, as well as pre-cancer treatment, because the current methods of treatment of pre-cancer involve surgery, removing of the cervix, and somewhat of a excisional and a high burden method. So we're trying to look at newer approaches, including immunotherapeutic approaches and topically applied approaches that women or men can actually use themselves to treat their HPV. But again, these are very novel, and because NCI works at a whole range of research that extends from basic science all the way to translation and implementation and dissemination, we are taking that approach of improving some of our understanding and knowledge about HPV and translating it into some of these interventions globally. The principal deputy director of NCI, Dr. Doug Lowy, and his colleague John Chiller were amongst the inventors of the HPV vaccine. So we have a rich history at the NCI for improving on some of these knowledge basic science knowledge that's generated as a result of taxpayer generosity and efforts that have led on to these discoveries. And then we are now trying to take it into scale and trying to prevent cervical cancer globally. So I can stop with that, but I'll probably open to questions, perhaps. Oh, yep.
Health field questions, because we have Congressman Upton here, and we want to be able to get everybody in. Does anybody have a question out there? Do I see a hand go up, or are we all set? Are we good? Okay. Becca, I'm sorry.
So I'm just curious about the self-swabs and AI are in the works. But I know that we're going to have a higher incidence of cervical cancer. So I was wondering, in the meantime, what efforts are underway to improve access for rural women to
So it's a great question. I think we are focused currently. There is a rural cancer initiative that the Division of Cancer Control and Population Sciences is funding, which includes improving HPV screening in rural areas across the US. And there are aspects such as improved last mile connectivity through telehealth approaches for education, perhaps, or there are facilitators for bringing participants back in or getting the results through some telehealth forms that might improve some of these access issues. Obviously, the last mile is geared towards solving that access issue. If we can send the swab home and bring this, only the positive people back to the clinic rather than getting everybody in. But it's a great question, and obviously there are a lot of challenges remaining.
I wanted to thank Dr. Sasha Boudet for coming and being part of this. I have something for you I just wanted to give you, and I really appreciate you being part of this. Thank you very much, and thanks for everything. Can we take a quick picture here? Yep, Doctor, can you scooch in here? Board members, can we step up quickly? Sorry. Sorry. Sorry, you can scooch in. Yeah, cardboard cutout. You know what? We're the ones getting all the exercise. Everybody should be standing at their desk. Okay. You guys want to do a stretch? You can. Thank you, and thank you for your patience, but this is how we tell the stories. We're going to have a bit of a switch up here. Congressman Upton is here, and I'd like to introduce him and welcome him to say a couple words. Thank you so much for everything.
Well, it's nice to be back. And I am only going to say a few words because I know you've got a cram schedule and you weren't quite sure when we were going to come. I was going to come with my partner, Diana DeGette. The two of us were able to shepherd through 21st Century Cures, which was literally the last bill that President Obama signed into law. It passed 392 to 26 in the House, and I want to say I think it was 92 to 8 in the Senate. But it was a remarkable bill in that we listened to different groups all over the country, including this one. And we tried to figure out how we could expedite the approval of drugs and devices and actually get them into the marketplace sooner. So we went to places like MD Anderson and University of Michigan and Harvard. I don't know if we went to Harvard, but maybe some did. I didn't go there, but all around the country, colleagues at our committee, we actually passed it out of the Energy and Commerce Committee, of which I then chaired it, 53 to nothing. Remarkable in terms of getting it done. And we coupled it with more money for health research. In essence, $45 billion more dollars over 10 years. For the NIH, we asked the FDA, the Food and Drug Administration, we said, all right, here's what we want to do. We want you to approve these drugs, obviously safely, but faster. What is it that you need? And they thought we were joking. So they said, well, we need $250 million. Said, okay, we'll give you $500 million. Oh! That's what we did. We gave it to them. And we passed it. It was a remarkable thing. We included the Beau Biden cancer moonshot incentive. I mean, that was part of this bill. We included $1 billion more for mental health. I mean, it was really an amazing bill that we got through. That was now 3 years ago. So now, Diana DeGette, and you don't know me from Adam probably, but I'm a Republican. She's a Democrat. She was going to come with me and be here, but she's chairing a subcommittee, and I just left the subcommittee. We're different subcommittees. So I came down here because I knew she couldn't come, so we're not here together. But now we're looking at doing a 2.0 bill. What is it that we missed? What is it that we've learned after 3 years that we could improve on what we did? And we have received, I'm not kidding, about 450 different suggestions on a whole variety of things. We met with the head of the CDC a couple weeks ago. We met with HHS. We're meeting with, different groups, not only patient groups, but, researchers and others, to see what is it that we can do to improve what we did. And next month, we're intending to introduce a draft bill, a draft document, that'll get comments, and we'll have more roundtables, some hearings. I'm sure we have, I think, the buy-in of the leadership on both sides, Republican and Democrat. Talked last night briefly, very briefly, remember it was the State of the Union, with some of our Senate friends. They're interested in seeing what we're doing because, time's short. It's short for everyone that gets cancer. The president indicated in his speech last night that he's going to provide $50 million more above and beyond where we are on childhood cancers. That's terrific. Maybe we can double it or more. I mean, we'll see. The budget, which comes up next week, just begins the process on the funding priorities for the whole government. And we've been blessed, and, often in the past, every president, Republican or Democrat, they try to balance the books. They try to get the budget balanced, and they play some games, I'll call it that, where they shortchange things knowing that Congress isn't going to go along with them. So I'm from Michigan. Anybody here from Michigan? Yeah. All right. So one of the things the president did before, last couple of years, is he's eliminated the Great Lakes restoration money. He knew that wasn't going to happen. It's not going to happen next week. We got the money in there, and they finally cried out. But they play games like that. So they played games with the NIH, the National Institutes of Health. We're not going to let them do that. And we have some very strong supporters, again, both sides of the aisle, to make sure that we have an adequate level of funding to get those resources done. And we're going to continue to do that, knowing that that was part of 21st Century Cures. So I feel, sorry I got a little bit of a head cold, but I feel encouraged that we're going to get this done. Diane and I had a wonderful partnership, and we got this thing done. And so we're going to need your help, because when we introduce it, so I don't know what the discussion draft, we got to put pressure on our colleagues. They got to say, yeah, we want to co-sponsor that bill. We want to speak for it on the floor. We want to get it done, because time is short, particularly in an election year. You got fewer legislative days, you got crankier people. They're going back home maybe a little more often than they did before, especially in the Senate if it's a 6-year itch. But we got to show that we have the momentum to get this thing done. I'll leave you one story that's really a direct result of what we did. So, pancreatic cancer, right? 5% survival rate. It's been that way forever. Lots of reasons. So because of what we did, just as an example, I've met with a privately held company that's got some trials underway for stage 4. And they're really promising. It's incredible. The cost is tremendous. They're paying 6 figures and more for each individual through these trials. So for the first wave of folks, there were 36 people, over 20 clear. Should be 2 or 3. They've expanded that base. I think they're over 100. Again, it's really good. I mean, this is really the last company standing that's actually got a trial that's underway. The others it's been rejected because it didn't work. 21st Century Cures because those results are so promising, if they continue just for a little bit longer, bingo, done. So, you know, we worked with Michael Milken and others in different groups. I mean, it's amazing the change that we've seen and the ideas that they've shared with us to try and get this thing done. So I just want to say thank you. We're going to be back to you, because especially if we get this thing introduced, we're going to need every one of you from all your states beyond Michigan. We got all but one in Michigan to vote for it when it came through the first time. But that's how this process works. This is a disease that, you know, we've made really good progress, but we know that none of us are, you know, I've got family members who've survived cancer and some that haven't. So thank you. Thanks. Okay, board members, get back up here.
Thanks, Miles. Sorry about this. And then we are. We appreciate it. Yeah, we just had the governor speak through our camera here.
Yeah, we had 2 or 3 talks. Good.
Yeah, it was all good. So, thank you very much. I appreciate everything you do. Thank you. Thank you, Congressman. So, I was just about to call it Mindy Mesmer. Where's Mindy? She ran out the door. Oh, selfies. I got her. Come here, Mindy. Oh. Here we go. I keep introducing Mindy Mesmer every time, and a new congressman shows up. I'm like, what is this? I'm just going to say Mindy Mesmer all day long, and there's somebody new. I have to put you on hold again. Rokan, please come up. I appreciate all you're doing in the area of PFAS, and thank you for stopping in and saying hi. If I can hand you this and you can say a couple words, that'd be great. Thank you very much.
Thank you. Thank you for inviting me again. Thank you. It's a good thing that a lot of members of Congress are coming by. That means you've been effective in getting this on people's radars. And PFAS, in particular, has been an issue that really has been a high priority for our caucus. We just, as you know, passed a bill which Debbie Dingell led to have a comprehensive solution to PFAS. One of the provisions that I worked with Mindy Mesmer on was requiring, we wanted a full ban of incineration. We got a compromise, at least. It has to be treated as a hazardous waste, and there have to be safeguards for how we dispose of PFAS. But we're going to continue to push, and of course the challenge, like anything around here, is if the Senate will do something, and if we can get the Senate to pass it. But, you know, we're way behind other countries. Other countries have far more regulation when it comes to PFAS. When you look at Europe in terms of how they regulate it, our EPA has really dropped the ball on this. And we aren't living up to the standards that scientists tell us we need to. More broadly, we need far more investment in water infrastructure. I mean, there are still 1.6 million Americans without clean drinking water. And most scientists tell us that we need about $35 billion to improve our water infrastructure, because 45 million Americans aren't getting water without certain contaminants. And we need that infrastructure investment. It also, by the way, would create thousands of new good jobs. And many of those jobs would be in the trades and construction. These would be blue-collar jobs. So it's a win-win. It improves our water. It makes it easier to live in communities and safer to live in communities, and it creates jobs. And that's something that I wish were more bipartisan. Brenda Lawrence and I have the bill on the Water Act. But let me end with this, and I can't resist being a little bit partisan. The fact that the President of the United States would recognize Rush Limbaugh for the Presidential Medal of Freedom who I can't think. I mean, our founders would be rolling over in their graves if to have someone of that caliber be recognized. And at the same time, this president has ended giving out the Presidential Medal for Science. I mean, can't they find like the Rush Limbaugh equivalent of scientists? I mean, they've just said no to science. So we should understand what moment we're living in, because this is not a moment of, oh, there's some Republicans, they're thoughtful, Democrats, they're thoughtful. That's the case if you're dealing with Mitt Romney, who I disagree with, but, you know, very thoughtful person who I think is wrong on a lot of issues. This is a case of a willful blindness to the Enlightenment values that founded America. It's a willful blindness to the philosophical traditions that founded this country. Our founders were intellects. They believed in reason. They didn't believe in passion and emotional manipulation. They believed in facts, and many of them were scientists. So to have people of your background with science and technology come to the Capitol to remind people of what should matter, what governance should look like, I think is a real service at our time. So thank you for what you're doing.
Miles? Tom? Miles is in the back. 40. We all love science. Thank you so much for being here.
Thank
I
you
have
for
a pen
inviting
for
me.
you too. One second, right here. Do I dare say Mindy Mesmer's name again? It's like, you know, the show Bewitched. You say Mindy Mesmer, poof. Okay, Rokana, thank you very much. We're so grateful for your help. Thank you. Thank you very much. Oh, I forgot to give my skin. What am I? Hello, hello. I had this for you. Sorry, I had other people giving me cues. We're so grateful for everything you do.
Thank you very much.
Thanks for working so hard. Okay, now I can say Mindy Mesmer. Come on up, Mindy, and you're going to introduce Doris, and I appreciate everything you do.
Thank you. Thank you, everyone, for hanging in there. We got a couple of good stories for you now. I am, so the first instance of this PFAS contamination happened in my state, in my town next door, where we detected PFAS at really high levels at a water well that was shut down in 2014 that was put for some reason in the middle of an airstrip on an Air Force base. I don't know why they did that. They thought that was a good idea. So that well was shut down, the biggest supply well on the seacoast of New Hampshire. We then started to unravel this situation. And as Representative Kildee said, there are over 400 bases just like ours in Pease, the Pease Air Force Base in Portsmouth across the country. So we're beginning to unravel this situation. And we have done a lot of work in passing some important legislation in the state of New Hampshire. We have really done some work trying to get enforceable drinking water standards both on the state level and the national level with many of our partners you heard from today. And that involves moving people along with us. And as Representative Kildee said, you don't always make it on the first try. But important steps are taken in bringing more people along. You heard Representative Kildee say that some of the people that should have been more supportive were then more supportive after that NDAA failed. So there's a variety of ways we do that. We do that with our partners like our Representative Rokana and Representative Kildee. We do that with inspiring, someone else, I think it was Rep. Kildee, talked about moving people as well. So we formed an organization called New Hampshire Safe Water Alliance, and I'll ask you guys to all go on Facebook. I know Facebook's a little old for you guys, but we have a group on Facebook called New Hampshire Safe Water Alliance where we work together to form coalitions to inform people, to motivate people, to inspire people to get involved. Through that process of that work and through the process of Pease Air Force Base, I'm involved with restoring the aquifer. I met this wonderful woman, Doris Brock. And Doris Brock is the wife of a veteran who has died, an Air National Guard worker who was at Pease. And so part of the effort of bringing people along is to have these people's stories be raised so they can have a personal connection with what is actually going on and how it impacts the people. So I'd like to bring Doris up to to present her story to you. And this is part of our effort to help people understand how impactful and how important and serious the situation is across the nation. Thank you very much, Doris Brock.
Thank you, Mindy. I can use the handheld.
Okay, that's great.
Okay.
Thank you, Mindy.
Thank you, Mindy. And I also want to thank the Less Cancer Organization for inviting me to share my story with you. It really does impact everybody. And I'm going to be telling you about the military installations. And I have a personal connection to the military installation because my husband was in the Air National Guard. And when you talk about the Air National Guard, you think it's just a weekend warrior kind of thing where they only do their 1 week in a month and 2 weeks of active duty a year. My husband worked at Pease Air Force Base for 35 years, 7 days a week. He worked there as a full-time guardsman, and it was a wonderful life. Military life is really, a wonderful thing. We're a big family. We all, get together. It's just when this came about, and I want to talk a little bit about how this came about. When he retired in 2005. I was still working, and several years later, he was diagnosed with stage 4 bladder cancer, and it affected his prostate as well. And at the time that we got this diagnosis, we were told that he had 3 to 5 years to live. It was at that point that I left my employment and became his full-time caregiver. And you don't think about, what would cause that type of cancer. His surgeon, when we met with him, asked him if he had ever gone to Vietnam. And we thought it was a funny question. But what he said to us was, and that was the thing that actually clicked in my mind, was that, why are you asking this question? He said that his cancer was very consistent with what he had seen in those people who served in Vietnam and had been exposed to Agent Orange. So when that clicked, you start doing a little bit of research, and you find out that there's more people out there that are affected, through their military service. The National Guard, has been the almost active duty Air Force, Army, Marines since 9/11. There were a lot of base closures back in 1990, and so the Air Guard actually took over, or all of the Guard units. So they became the deployable units. So in looking back at this, while my husband was ill, we had friends, that contacted us and said, did you know that so-and-so had this cancer? Did you know that so-and-so had this cancer? And the bottom line of that is that at that particular point in time, I had a list of 62 names that were our friends, and 39 had died from cancers, many before the age of 65, which is really a very high number, and it's just our friends. So I just, and then I became the caregiver, didn't really do a lot with it. He passed away in June of 2017. I actually didn't do anything with that for quite some time. But the numbers, there were people who were still getting in touch with me during that year after he passed, and the numbers started climbing. And if you ever wanted to get the attention of any military installation, do an interview with media. That works every time. So I did this interview, and I talked about this, and only my personal story, and described the numbers. And our Air National Guard actually got wind of it, and so did our delegates, and they wanted to do something about that. It took 4 months for them, to pull something together, and we did create the Pease Health Work Group. And this Pease Health Work Group, what they were planning on doing, or what we tried to do, is talk about prevention, talk about alerting the military that there is a possibility that they were exposed to toxins in their workplace. And the reason why I did that was because I had read about the PFAS on the seacoast. I moved away. I live 3 hours north in the North Country, so I don't pay attention to any of that, in the lower part of New Hampshire. But I read that and I got mad. And the reason why I got mad was because they kept on talking about the firefighting foam. And in the case of the military, you're talking, people who've been exposed to very, very volatile toxins. My husband, in the start of his career, worked with jet fuels and petroleum products, other petroleum products. Then he went to aircraft maintenance, and so there were solvents, paint strippers, and a lot of other things. And at that time, the military never had a hazardous material program until the late 1980s, prior to the closure of Pease Air Force Base. So when you look at that and you think back of these men and women who washed aircraft without any proper protective equipment, these people bathed in jet fuels, bathed in everything else. And then we had the firefighting foam on top of that, and they drank the coffee. They made coffee every day. And I had an old timer, he's in his 70s, and he came to me and he goes, well, we never drank the water. He goes, we knew not to. And I said, did you drink coffee? He goes, several pots a day. What water did you use? So it was really just kind of, it's funny but not funny, when that happens. So we did have this health work group, and we did get people together. The health work group actually thinks that they've done what they set out to do. Because first, they can't be legislatively involved because they are a component of the Air Force. But we did inform the retirees and anybody that we could get a hold of, about how to speak to your doctor. Where can you get the material, to tell your doctor what you've been exposed to? Because, if you go see a doctor and they tell you, they say, what's wrong with you? And they develop a cancer, and you don't tell them that you worked in the military for so many years. And so we wanted to educate them on how to do that. So that did happen. And then 2 weeks ago, we were fortunate enough to get a study. And I will say that when I first heard about the study, I was not happy. And the reason for that is that the U.S. Air Force School of Aerospace Medicine is going to do a mortality study. And I really wanted to impact the people, that I work with. These people are like your grandfathers, and, they're my best friends. So when they talked about doing this mortality study, I finally calmed down and I realized that this is the best we can have today, but I want to move it forward, to look at doing a cancer incidence study. When I told you about the 62 cancers, the cancers that these people had are all organ cancers, with some blood cancers. But they're pancreatic, bladder, liver, kidney, and that to me is just an unusually high number of cancers in one particular area. So we have that going on. I'm excited about this study. Mindy's going to help me move forward, so that we can get this other study. And then the Veterans Administration is my other. I'm working to try to get the Veterans Administration to look at, our military members, for those that served. And I realize that you have to have had, a number of years in order to qualify for some of that. I've been fighting the Veterans Administration for the last 5 years, and 3 weeks ago, I got my denial. And so I'm continuing the process. And the denial is, I can't prove service connection, and he didn't die within a year of his retirement. And it's just, yeah. Oh, and my first one was the best excuse is, and it's not tuberculosis. And it's like, okay. So it's just, it's a battle, to fight. I feel that if we can just help these people, and get them to tell their doctors what they were exposed to, that we'll be so much better off. Fighting the Veterans Administration is a whole other, topic. And so I'll continue that fight. And my reason for doing that is because Camp Lejeune is a Marine base. It took 35 years of studies for Camp Lejeune to get presumptive disease to apply for disability based on presumption. And so when I look at the definition of presumptive, it's presumed because of a lack of information. And that's why I'm fighting, to get them, the disability that they deserve. So that's really my story. And, I just wanted to share that with all of you. And for all of you, the high school students here, I was trying to think of how I could connect this to you, besides being grandparents. And that year that I didn't do anything, was a big mistake. But it gave me time to regroup after my husband passed away. And getting mad and actually getting involved, okay, in your community and with other people, is the best thing that you can do. And I'm not sorry that I got involved.
Neither are we.
Thank you.
That was so nice. I appreciate it. Can I have a hug?
Thank you. Yes, you can.
Thanks. It was really nice. Can we do just a quick picture with Doris here? They did. We're just gonna, because we're gonna start the thing. I just want to do it quick with Doris. So, Doris, thank you for your work and your service and your interest. And I think Doris is a good model for something when you see something that doesn't sit with you, you just keep on knocking doors. That's how Less Cancer started in 2003. It was like, a bottomless bag of potato chips. I just couldn't get enough answers fast enough. And at the time in 2003, they said, oh man, prevention, cancer, it doesn't really go together. We don't know what you're talking about. Today, every expert, cites it as the best solution for bridging the gap on increasing incidences on cancer. So we've come a long way, and I, like Doris, started knocking on doors. So we love our door knockers, and we love you, Doris. Thank you so much for your help and leadership, and you too, Mindy. Thank you very much. I don't ever mean to rush along here, but we're about to start our next panel. So if we could have Miles, would you like to introduce your panel members? Okay, good. We all know this guy, Miles O'Brien. He's a Less Cancer board member and critical leader for us here.
Give a round of applause to Bill Cousins for what a great day. It's often tough being the last act. Come up, ladies. We don't have too much time. What time do we have until Bill? Till we turn into pumpkins here?
Like 3.
We have till 3. We have to solve tenacious environmental problems in 30 minutes. We can do it.
We can do it.
So I see some young people here. I see some old people. Now the old people will remember a show from the 70s called Charlie's Angels. Remember it?
Yeah.
Yeah? You guys have no idea what I'm talking about. Do you know anything about it? There's like a new version of it. So basically the premise is 3 badass women kicking ass and taking names, putting the crooks in jail. Well, I'd like to submit to you right here, these are Bill's Angels. Except they're 3 badass women kicking ass, taking names, trying to save the environment. And what's kind of sad about it is they're fighting some things that we first started talking about when Charlie's Angels first came on in 1976. Stubborn, ubiquitous, but fortunately you guys are stubborn and ubiquitous as well. By the way, a lot of people ask me all the time, they say, where do you get your story ideas? I say, Bill, because last year I did a story with Linda. I'm doing a story with Mindy right now. You're next, Ellen. So that's Ellen Hahn from the great state of Kentucky, who has the temerity to be anti-coal and anti-tobacco in Kentucky. She is a marked woman. If she sees Mitch McConnell, she has to go the other way, right?
Yeah.
Linda Reinstein is a warrior. He goes the other way, she says. Absolutely. Yes. Thank you for that correction. Linda Reinstein, who's been waging war against asbestos. How many people here thought asbestos was banned by now? Raise your hand if you thought asbestos. Yeah, most people, you say asbestos. Oh, we got rid of that. No, she's still fighting. And Mindy Mesmer, of course, we've been talking about PFAS a lot today, and we're doing a story with her, as a matter of fact, next week for the PBS NewsHour on that difficult subject. So Under the umbrella of difficult environmental problems, which we try to fight, and yet the regulatory process doesn't seem to want to move, we bring you Bill's Angels. So, Ellen, let's start with you. And because this is, you know, my reporting career of now, I hate to say it, 40 years. When I first started doing stories, I was doing stories about radon. Radon solved? No. First of all, why don't you tell these young people what we're talking about when we say radon?
Sure. Can I just say the bigger context is good news, though?
You can say anything you want here.
And that is that lung cancer is totally preventable. And it really, it's the kind of cancer that's totally preventable. And it's really caused by, you probably know the number one cause, and that is smoking. Yeah. But the second cause is radon. And so radon is a colorless, odorless gas that's in the rock and the water and the soil beneath our buildings. And it's a radioactive gas that comes from uranium. And we can't really get rid of it, right? Because it's in our soil, it's in the crust of the earth. But the problem is when it gets trapped in buildings like this one, or mostly your home. And, you know, it's where we sleep. We spend most of our time at home, whether you're in an apartment or a house. And so radon is a gas that is the second leading cause of cancer.
And not many people know
Lung
about this. And so there are ways to detect it. There are ways to mitigate on this, but not every state requires this. As a matter of fact, only a few do, correct?
Right, very few states do. The good news, though, I like good news, a little bit of good news. So yesterday, I guess the Housing and Urban Development came out and said they were going to increase funding for radon testing and mitigation in HUD housing. So that's a good thing, right? We've had a law in the books since the 70s saying that HUD housing has to test and mitigate, fix radon. They don't.
Yeah.
My only concern about the federal law, or the federal decision, I guess, and I don't know much more about it yet, but is that I think it's going to have a little hook that states have to pass laws to actually use the money in that way. So that's worrisome because we really don't have the political will to do anything about radon.
So just quickly, if you could explain how your work on secondhand smoke and smoking in general led you to radon.
Yeah.
It's kind of interesting. And for one thing, I thought we sort of solved the secondhand smoke thing, right? We're not smoking
Well,
in bars
in Kentucky
anymore
and Virginia, you know, the tobacco-growing states still have an intractable problem with tobacco. We have very weak policies. You know, about 60% of Americans are covered by strong smoke-free laws, but that means 40% aren't, and Kentucky's one of them. So some of the urban areas have good, strong laws, and that's great, but there are a lot of talk about rural disparities. There are a lot of rural areas where people go to work every day, and they're exposed to secondhand smoke. And most people know secondhand smoke's bad, right? But you might not know there's 7,000 chemicals in there, and 70 of them are known to cause cancer. And so we know that it is a cause of lung cancer and actually several other cancers as well. But here's the connection. My career as a scientist and a nurse started with tobacco control, and really because I have severe asthma. It's the same story you've heard all day. People have personal experiences with these things, and that's what prompts them to go down the path. And so my career as a PhD nurse doing research, doing science, I've been doing tobacco control a long time, but I realized that there were non-smokers who were getting lung cancer. And I thought, interesting, 53% of the non-smokers that get lung cancer are women. And I was like, that's weird. Why is that? Well, they're in their home. And so then I started going down the path of looking at radon. And I'm a public health nurse. I mean, I've known radon's a problem for years, right? But I really never put the two together. Well, come to find out, in 2005, the Surgeon General issued a health advisory saying that radon and tobacco smoke are synergistic, meaning that if you are exposed or have been in your life to tobacco smoke plus radon, your chances of getting lung cancer are tenfold. And I was like, wait, what? You know, so I think it is an intractable problem. People know about it. Sad part is very few people test their homes for radon. And we have we have lots of silos. I know that's surprising to the people in this room, right? But there's what we call silos in public health, you know? The money's over here through the CDC, maybe for tobacco, but then who funds radon? Well, it may be the EPA and, you know, maybe these other groups. But my research has pointed me in one direction, and it's a simple thing, a simple solution that we need to be doing, and that is the tobacco people need to encourage radon testing. The radon people need to be encouraging people to quit smoking and make their homes and cars smoke-free. And it sounds so simple, but it's not, trust me. I've talked to, nursing, medical, other organizations around this country about this, and they just kind of look at me like I'm crazy. But if every clinic and hospital and healthcare facility would give away free radon tests, they're not that expensive. Why aren't they doing it? Why? Anyway, so.
All right, well, that's a good start for some of the issues. Linda, I don't know if you noticed when you were walking down the hallway here, there's kind of a groove in the hallway that actually Linda, I think, has created over the years from walking up and down here, browbeating congressmen on the issue of asbestos. Linda, who lost her husband to mesothelioma now several years ago, and who has turned that into a long crusade to, you can stay seated or go to the podium, whatever you prefer.
I want to see the millennials.
Yeah.
Oh, you want to push the podium? Or sit on
that's
that
why
side.
I was like,
Maybe we'll push the podium back so you can see better. So here's
the millennials that are still away.
But Linda, after you've been doing this, we've been doing this how many years?
15.
15 years, and this year, in spite of the occupant of the White House, you made some progress on this end of Pennsylvania Avenue. Tell this group what you've done. Maybe we should back up a little bit, though, and just give a quick primer on asbestos and how there is such a solid link between it and mesothelioma and other cancers.
Great. So it'll be quick, and there'll be a test at the end at 3:15 out in the hallway. So the reality is, we in the United States, over the last 100 years, have imported and used over 31 million metric tons of asbestos, which can be found in your homes, schools, workplaces, and on consumer shelves.
Makeup kits for kids,
That's
right?
correct. The
That's a
FDA
good
just
place
had a
to put
meeting
asbestos,
yesterday.
don't you think? Go ahead.
That's correct. FDA had a meeting. So the EPA tried to ban it. Makes sense, right? If it's a carcinogen, it should be banned. Well, the industry is very strong, as you will find out in Washington, and it was overturned in '91. So as a result of Alan's illness, along with many others, and of course Bill and Less Cancer, we have been fighting to get a ban. And I'm excited to share that we have the 5th iteration of the Alan Reinstein Ban Asbestos Now Act. It's bicameral, which means it's in the Senate and the House. It was voted out of the Energy and Commerce House Committee, which is very powerful, with a vote of 47-1. Do you guys know what that means? That means the Republicans and the Democrats agree, except for one knucklehead, that asbestos...
You got to name names, will you?
Yeah, he's from Oklahoma, sorry. I can go further, but
You
that's
could look it up.
Yeah, but the reality is Congress is concerned, and the cost of diseases are expensive. When Alan was sick, it was over $1 million of medical expenses. That's a lot of pain and trips to the hospitals for preventable diseases. And like radon and smoking, same with asbestos, there's a synergistic effect. Does that kind of sum it up?
Yeah, that's good.
40,000 people
So-
die every year of preventable asbestos-caused diseases.
So get you 15 years. You're tenacious. There's no question. But are you reasonably optimistic that you're making real progress? And getting it voted out of committee is one thing. Actually, getting an outright ban is another matter, right?
Well, I think you know me by now. If I'm one of Bill's angels, yes, of course I'm optimistic. I've been working on a Senate strategy along with my colleagues. We have the leading doctors and AFL-CIO and APHA, Less Cancers on the bill. And you don't just look at the obstacles in front of you, you have to turn them into opportunities. So while we got a 47-1, which is huge, people are like, why are you bothering? It's going to die in Mitch's graveyard. I said, no. Other people are dying and end up in a graveyard, but this bill won't. So with your help, so I hope you're tweeting away, we're going to take this bill to the Senate. We're going to say, wake up. And then to the president, did you know that the president spent over $250,000, taxpayers, to abate the White House from asbestos? So I think we have a good...
Wait a minute. He's on record as saying he loves asbestos.
Well, he spent
Literally.
$250,000 of our dollars to take it out where Ivanka and Kellyanne and some of those guys are.
Oh, that'd be a good story
So
right
thank
there.
you for
See,
letting
I
me
get all
see
my
the
ideas
millennials.
right here in this room. It all happens here. All right, so Mindy, the PFAS story, although it certainly has roots for a long time, we've only been talking about it more recently. So you're the more recent problem child on the block. Give us an idea. One of the big challenges, even though there's legislation right now that's winding its way around, there's threats of vetoes, et cetera, but what's confusing about PFAS as much as anything is there are, I guess, about 5,000 types of PFAS. So figuring out a way to regulate this is an incredibly difficult challenge. It's, even if the EPA were interested, and we're not sure they are, to go through and analyze 5,000 distinct chemicals and determine whether they're safe or not is a big problem. Walk us through the complexities here.
So you bring up a good point. It is difficult, and that underscores a big issue with the way that we approve chemicals for use in the United States. We basically have
They're innocent until proven guilty
That's right.
here, which is, it is the opposite in Europe, by the way, we should point out. Right, so
Yep.
go ahead.
Yep. So it turns out that from the work that Rob Bilott did, actually, we know that for about 50 years, the industry has known about the health effects of these chemicals. They just hid it from everyone else. Even the Department of Defense and the EPA have known for at least 20 to 30 years about the health effects. There are 5,000 of the chemicals, and if you watch Dark Waters or The Devil We Know documentary, that was the beginning of that film, the industry is ahead of us in just modifying, tweaking the formulas of these chemicals to keep ahead of any regulation or any health studies that we can use to prove that they're not safe. So when they said that, they came out with some of the recent regulations on, or advisories from the EPA on just two of the 5,000 chemicals, they were already making and saying, oh, we're not using that anymore. We went on to these other things that are so much more safe for us, which we're now finding is not at all true. We think that they target the same organ sets that the original ones. And then in my state of New Hampshire, not only do we have Pease Air Force Base, but we have an industry called Saint-Gobain Performance Plastics that every day emits 190 of these PFAS chemicals out of their stacks, 12 of them every single day. And 147 of those the EPA calls novel. So EPA doesn't even know what they are. So this is a massive issue. The same thing's happening in places like New York, had happened in Bennington, Vermont. Stuff's happening in North Carolina, the same thing. They're emitting all these newer generation chemicals that we don't have any idea the health effects associated with. There's no health studies. They've got them on the market. They're making tons of money. 3M's making $25 billion a year in profit. $1 billion of that profit is from PFAS chemicals alone. So when we got some great strict drinking water protections in my state of New Hampshire after 3 years of my work on this, the very next day 3M sued the state of New Hampshire and was successful in getting a preliminary injunction in place on these chemicals so they can continue to make the $1 billion profit a year.
So go ahead, Lynn. And just to underscore that point, though, what you're saying is that they just keep throwing chemicals out there and wait for somebody to try to regulate them. The health consequences be damned. That's basically it.
Exactly.
All right.
Yeah.
Saint-Gobain is a French company that actually mines asbestos, or used to, in Brazil. So all of these big polluters come together in a really nice vortex, right? So I thought that was, when you said Saint-Gobain, I'm like, oh my gosh.
Yeah.
It's also a theme with the tobacco industry, and
Absolutely.
with electronic cigarettes more recently, and even prior to that with conventional tobacco products. They are always changing the product to get around regulation. So it's a theme.
Yep.
And if you don't learn anything else, to do good environmental public health, to fight cancer, you got to know who your enemies are. I always learned, keep your friends close and your enemies closer. You really do need to know who they are and what they're up to.
So in the current environment in this town, with an EPA that is seems to be on the other side of the environment these days, what we're seeing is, and Mindy, you get an opportunity to toot your own horn here. New Hampshire has, I think, the toughest regs now on the books because of your crusade. Right. The states really have to step into the fray here. Tell us a little bit about, I mean, on the good news, that's good news in the sense that at a grassroots level, people are taking action. But what it does, it makes for kind of a hodgepodge patchwork, bunch of regulations which may or may not contradict each other, et cetera. What are your thoughts on that? Is it, I mean, in the absence of help from the EPA, it's the only thing to do? Is that the idea?
Absolutely. And, I think each state should be able to protect their residents from exposure to these chemicals. I mean, New Hampshire, I got involved in this because I identified a pediatric cancer cluster. Children in my district had 2 forms of rare cancer that were higher than expected rates. Come to find out since then that New Hampshire has the highest rates of breast cancer, the highest rates of pediatric cancer, esophageal, and bladder cancer in the nation. So clearly, the state should move, and they have an obligation to move to protect their residents when EPA has failed. And I actually don't really want EPA to start moving right now, because with the current heads of EPA, I'm a little bit concerned about what they're going to do. And we know it takes a really long time for them to come up with enforceable standards. So I'd just rather them just say, yes, they're hazardous, and then everybody else take it from there.
Well, the EPA, even in its best days, was really slow. Let's
Right.
face it, right?
Right.
So, and maybe you're right, but just step aside, get out of our way.
Right.
Linda, what are your thoughts on when it comes to asbestos? You know, you've been focusing on legislation for a national ban. What's happening at the state level?
So that's a really interesting question, because state bills are much easier to write and to pass, but that doesn't mean that they do the job. So for asbestos, we could have a very ineffective and weak bill pass in the state, which it did, for instance, in New York, and it doesn't ban imports. So we don't want to have a patchwork effect. We actually want the EPA to stand up and bang their chest and do their job. So for some chemicals, it may work, and yes, it raises awareness, but for asbestos, it's a patchwork, it's a killer patchwork quilt.
Ellen, what about state level stuff when it comes to, well, the thing I'm thinking about right now, we did a lot of stories recently on e-cigarettes and vaping, and that was, the state reaction to that was all over the map, wasn't it?
Right. And of course, Michigan, did the right thing and banning flavors, because really we know, as Mindy said earlier, that children are attracted to all those flavors. And so when they ban just some flavors, then youth are using menthol and mint. I mean, they're still going to use those flavors, and that's what the research shows. But states have a role to play. Local governments have a role to play. And tobacco control is tough. I mean, we have 50 years of fighting the tobacco industry. I could tell you my war stories, but you don't need to hear them. But they are powerful. They have money. They fight. They would rather fight in Congress because they don't have to go as far, and they have lots of power here. So frankly, the tobacco control policy world has focused either at the state or the local level for years and been pretty successful. I mean, California is probably one of the best examples of that. But there are lots of nuances to policy change in tobacco control that we probably don't have time to get into. But
Just quickly, though, first of all, to the young people here, and we won't use your names or anything. How many people know or do themselves use e-cigarettes, vaping? How common is that? Everybody had direct experience with it? Raise their hand if you have. So about half. Now, in doing this story I did recently for the NewsHour, I interviewed a young man who developed the respiratory problem that was associated with some of the, with Volley, that's it, which is associated actually, I think, technically with the bootleg cannabis products, but he also was a heavy user on the tobacco, so it's hard to disentangle this. He said that his high school, at least 80% of these young people are vaping. That's a stunning situation. They are just all nicotine addicts.
well, the use of tobacco products, the good news, again, is the use of tobacco products among youth has gone down, traditional ones, but it's been replaced with electronic cigarettes and products. So, yeah, it is a problem. But I think it's a mistake to think it's all THC in there, because there's a thing called propylene glycol that people don't really talk about, but it's in those products. And the only reason it's in there is because it's a transporter. It's used in oil for your car, and the only way to get the oil to your engine is to have propylene glycol in there transporting it. And the same thing for e-cigarettes. It's in there. It's dangerous. It's a chemical that is probably one of the reasons why we're having all these pulmonary diseases. And it's in there to get the nicotine to the brain. And that's all. And they won't take that out.
But, to me, it's like Joe Camel for the 21st century when you have a, bubblegum flavored thing to suck on that makes you feel good, right? I don't know. Pretty sick stuff. All right, so Mindy, are you reasonably optimistic you're making progress on PFAS? It's such an unwieldy, widespread, we've used that term ubiquitously. It's a big one.
It is a big one, but when I was elected in 2016, no one in my state really knew what it was. And we've come a long way from 2016, a relatively short amount of time, to having the most enforceable, the strictest protections on our drinking water in the country, in New Hampshire. I'm also thankful for all the people and this venue, actually, for bringing all these representatives, the senators and congressmen, to the table here. You now heard, I think, at least 3 of them talk about PFAS today. And that's a huge development. And they are now working. We have our elected representatives from New Hampshire working on a lot of the issues here in Congress, along with people we met today. And I think we've made a lot of progress. Sometimes it's incremental, sometimes it's frustrating because things fail. But like Representative Kildee said, those failures actually help to promote an understanding and informing other people about how important these issues are. So it might look like a failure, but then you try again and you can be successful. So I'm positive that we're making a lot of impact.
You are unusual because you're in the public realm fighting for this, but you also have deep scientific background. Is it possible, do you think, to come up with a way to regulate this as a category of chemicals to solve this problem of, we changed one molecule and it's not in the book anymore, right?
It absolutely is, and in fact, we were part of a group of people that were trying to push for that on the state level and also the national level. We did it before with PCBs. PCBs are a similar type of situation where they just modified the PCB molecules, and there were different types of PCBs, and we did regulate those as a class. So it has been done before. It is, when we have the will, we can do it.
And in the case of asbestos, it's kind of similar. I don't think there are 5,000 versions of asbestos, but there are quite a few versions of asbestos. Is it make the regulatory challenge more difficult as well?
Well, it makes the regulatory more challenging because the industry still wants to tell you it's too long, it's too short, it's not from this rock, it's from over here. And don't worry about a thing, I care about your health. So when we argue about the science and they can pay for science, that's a problem. But as far as the fiber types, IARC, every leading agency says asbestos is a human carcinogen and there's no safe level. However, yesterday at the FDA meeting, I sat next to scoundrels that were saying it's not long enough, it's too long, and they're still arguing.
Explain, when you say long, you're talking about the molecular chain, right?
The
or the
size
of
the actual
it.
size.
Explain what that means.
The actual size of the fiber.
The fiber itself, right?
Yeah, if it's really short, the thought is it can't embed itself into the tissue. Or
Is
your
there
body
science
has
to say that's true, though?
No, I mean, you could pay for science, but the normal size is 5 microns. But if you start arguing about what rock, how big, why are we having that conversation? Any asbestos is a carcinogen. We shouldn't be talking about the testing methodology and the definitions. We should be working on prevention and policy and enforcement, in my humble opinion. I hope you guys don't get disappointed when you're hearing about all this stuff, because there's stuff you can do, and I'm sure Miles will touch on that.
Yeah, I just want to.
Well, let's do that now, because I know Ellen in particular has some stuff to talk about, and I want to see if we can get some questions.
Ellen.
But mobilizing, tapping into these. This is the OK Boomer moment, right?
Okay, Boomer
Talk
moment.
to the
Is that what
youngsters
it
here.
is?
See what they can do to save our sorry ass, will you?
We need you. We're motivated by you.
Yeah.
We really are. So we're doing a couple innovative things in regard to secondhand smoke and radon. One is we're in Appalachia and in northern Kentucky, so kind of urban and rural areas, mobilizing youth and actually engaging them, working with teachers and youth in high schools to join our research team. And we're training them in what's called human subjects protection. They are joining our research team. Our institutional review board has allowed that, which is amazing. And then they go out and consent homeowners to test for radon. They go out and use these little air beam machines that will measure air quality in the air, both in restaurants and outside too. And actually, the students themselves have come up with the sampling design for the research. I wish I can send you later. I can send it to Bill if you want. The link that the students in one of the high schools made, and it's empowering. What the students tell us is they feel like they're not just reading about science or listening to science in the classroom, but they're actually gathering data themselves. They're actually involved in reporting the data back to the homeowners and to the people in their community. And the most exciting thing is that they got on the bus. They had these little air beam machines for air quality, and they said, I bet it's bad on our buses, our school buses. And so they took the machines onto the school buses and did did find some really interesting things. So the really cool part, and I think that is a solution, getting not only youth, but adults engaged in what we call citizen science. Because once people see the data, it's powerful, and people feel empowered because they're part of the process. They're not just looking at me as a university professor doing science, but they're actually part of our team. So that's one thing that I think is really encouraging. The other encouraging thing, and it relates probably only to radon, but maybe to asbestos, I don't know, is that we've formed a really innovative partnership with the U.S. Geological Survey. And because radon comes from the ground, one of the solutions is to try to understand it more is we have to work with geologists that know about rock. I'm a nurse. I don't know about rock. I know about your lungs, but I don't know about rock. So we've really formed a really interesting partnership, and we're embarking in a large project with them. So it's just two ideas.
It's easy to take it for granted, right? Sorry.
Boomer joke.
Come back.
Thank you. Thank you. I'm here all week. Try the veal. Thank you very much. All right, Linda, give us some levers of hope to pull on, will you, please? And I'll try not to be punny about it.
Extra credit. So one is you have to hold hope closely. No, don't make a face at that. That's true, because because if we give up and feel it's so daunting and there's nothing we can do, then we lost the battle. You missed 100% of the shots that you don't take. So one is join the fight, whatever fight it is. Two, use your voice. Talk to Bill about hashtags. Just tell your friends you were here. If you say asbestos, radon, and PFAS kills, that, it's kind of a scary message, but you can educate your family and your friends and other students. And more importantly, know that change can be started with one voice. And don't give up. And use your talent. Storytelling is amazing. You could write something and ask Bill and I to publish it about what you learned about asbestos today. So, and hold your dagnabbit lawmakers responsible. If they're not on our Alan Reinstein Ban Asbestos Now Act, and I'm happy to send Bill the link he can give, call them up. Tell them you heard the news, that you can save 40,000 lives every year. If we start now, we can work to prevent asbestos-caused diseases. Use your voice.
We need to get involved, all of us. Mindy, preach to the young choir there, will you?
Right. So, as both Linda, both people have talked about, it's really important to use your voice. And New Hampshire Safe Water Alliance is a coalition we formed. It's not just New Hampshire; it's across the United States. We have members from everywhere. And you know what? The Sunrise Movement and the young people that have stepped up to talk about the climate change issue has been so impactful. And drinking water protection and climate change are integrally related. When we look at sea level rise, it doesn't always come from overland, it comes from underland, and will impact our groundwater aquifers. So protecting our aquifers from chemicals and protecting our people from getting cancer through ingestion of exposure to toxins is super important. And when you guys step up and talk about gun violence prevention or climate change, we listen, and it is very, very impactful. So I encourage you to just find your space, and when you see something, say something. I got involved in this because I blew the whistle on a pediatric cancer cluster. It changed my life. And that will become your goal, to make sure that we listen to you guys and that change actually happens, and it will happen. And so we have to turn around now and not give the chemicals the benefit, but use what's called the precautionary principle. And if we know that they're bad, like we know some of the, regardless of the length of the fiber, that causes mesothelioma, then we don't give the chemicals the benefit. We give us the benefit. And we need to change that around. And we need your voices to do that. Call your representatives, all your representatives, email them. They have to listen to you. Even if you don't think they are taking notes on what you say. They do track what people say. They track how many calls they get, and it's really important.
Yeah, if you think if you think it's not worth your time, I have two words for you. Greta Thunberg.
Yes.
Right? You can change the world. All right, so I think we're in bonus time, but if there are any questions, can I squeeze a few in? If there's any, does anybody have any questions you'd like to ask Bill's Angels? Yeah, hang on one second. Over here.
One of the things we talked about, all the panels talked about the racial disparities within all of these cancer risks. I look around the room. What are some of your strategies to involve the people in those communities that are most affected?
That's a great question. We are starting to focus on low-income people in rural areas. Our state is primarily Caucasian, although we do have pockets of racial ethnic minorities. We have quite a bit, a growing Hispanic population. So we have a project that we're just starting, working with community health workers. And if you don't know that term, it's a lay worker. It's somebody who's not trained as a nurse or a doctor like me, but they live in the community. They care about health. We train them in basic skills. They get certified. They are part of the healthcare team. And we're starting to work with them to address tobacco use disparities because they are in the community. They know the community trusts them. And in my opinion, it's the only way to reach racial, ethnic, and other minorities. I mean, there are a lot of other disparate populations that are affected by tobacco and radon, because there are a lot of people in rental properties who really don't have any control over fixing it, but yet they don't know, they want to test, but they don't know how. So it really is trying to find the messenger, in our opinion. Yeah.
Any other questions from the crowd? Oh, you go ahead. Linda.
That is
Yep.
a great question because it's very difficult. So we have two approaches. One is we develop educational campaigns that are easy to access and you can understand them in different languages. That helps us to reach other populations. But we also have to work with universities, and I think when we work within the school system, whether at high school or our universities, that allows me to work with millennials, and it's very exciting because they become our new champions. So using simple education in universities.
Mindy, you want to say something about that?
Well, in my state, we have a lot of economic disparity. So we are doing some of the same things that Linda was talking about, just educating and informing people, going into the communities and trying to involve people in understanding the issues.
All right, I think we are. Can we squeeze one more in, Bill? One more question? All right, let's do one more. All right, yeah, go ahead.
If you were to test your home or school bus for radon and it came back as not good, what would you do about that?
Yeah, that's
Hold your breath on the way to school.
Hold your breath.
No, what'd you do?
Well, testing is really easy, and it's the mitigation that really it's not any more expensive than like if you're going to do a home repair, but it is expensive, and that's the barrier. And you can't just fix it yourself. You need a certified radon measurement and mitigation professional to do it. Some people think, I learned a little plumbing here and there. I can just fix the cracks, but you really do need somebody to come in. So it's somewhere between, depending on where you live, $1,500 to $2,500 or $3,000, $2,500 to $3,000 to fix it. Now that sounds like a lot of money, but there are ways to help folks with those costs.
All right, can we do one more? What do you think? All right, yeah. Okay, let's do this. Go ahead.
I know you talked about your work with Congress, and I think most of us are from Virginia. How helpful and how supportive has the Virginia congressional delegation been with your work?
Marginally supportive. It tends to be thought of as more Democrat versus Republican, unfortunately, in Virginia, but it doesn't mean that you can't help me change that, and I encourage you to use Twitter, so, yep.
And I will say that Virginia was the first place where there was a National Cancer Prevention Day. It was actually sponsored by Jill Vogel, who is a Republican, and that was done over 10 years ago by Virginia and a Republican legislator. So.
Okay, I think we're about out of questions and time. Is anybody else going?
One more.
Oh, I'm sorry. One more. Yes.
So you spoke about the importance of informing the youth about many of these public health concerns. Is there a way to embed that into the curriculum? Because I know that would be a really effective way of allowing the youth to know, but I mean, there's probably challenges that you guys have faced with doing that.
Do we probably all have something to say?
All three at once. Do it simultaneously. Just save us some time.
I mean,
start with you, Mindy, and move down.
In New Hampshire, we are having some big problems with our education system. We have a head of the Commissioner of Education who doesn't believe in science, so it is a big issue. And unfortunately, we have to work to elect people that represent our values, and these are nonpartisan values, really. There's not any Republican or Democrat, is not necessarily going to be on board with us. So it's about educating people and about working to make sure those people that you feel represent you are elected.
But Ellen said it. If you have a question or if someone's talking about a chemical, whether it's on a TV commercial or something that you see that doesn't sound right, I implore you to ask questions, to challenge authority, and then take your voice further. Whether or not you write members of Congress or you contact those in the space of NGOs, we can answer your questions, or we will do our best or find someone that can. So use your intellect and your knowledge.
So it's a great question. We have integrated it into the science curriculum in some of these schools. Our goal is to go higher and have the state do it. But anyway, and the other thing we've learned is that you have to build it into the teacher's professional development time, and so that there's incentive for teachers to want to do it. I know there's some teachers here, and we've learned that. We've learned that from them. So there's systematic ways that it can be built into the curriculum. Yeah.
Great question.
Yeah, it is.
Yeah, so, clean water, clean air, that should be bipartisan. I mean,
Yeah.
you kids may not remember it. The EPA was created by who? Richard Nixon. Who created the national parks? Teddy Roosevelt, another Republican. Who was among the first legislators here to push for cap and trade? John McCain. So this used to be a bipartisan issue, but unfortunately, corporate interests have changed that, put their thumb on the scale, and you guys had to fix it because we messed it up. So anyway, Bill Cousins, you rock. I just want to tell you, we've been doing this now since, we started this in the mid-'50s. In the mid-'50s, we started coming in here. But no, it's grown every year, and you've done a great job. Thank you for having us all here. It was very good.
I want to just take a special thanks to Miles.
Yeah.
Miles is an amazing guy. He's got lots of journalism jewelry in his house, the statues they called. What are they? Emmys? Something like that? Anyway, we're super lucky to have his leadership and lucky to have all your leadership. I just quickly wanted to wrap this up quickly. If we can get a quick picture with everybody in front of the screen, all the students and everybody together, that would be great. But I first wanted to thank you all for being part of this. You're all part of the change. You've always been part of the change. You've always shared our stories. You've always told our stories, whether it's in Instagram with a hashtag of less cancer, or you're telling a family member. You're the ones that have advanced this agenda. This organization was founded for the next generation. It was founded to help the next generation and their children's children, so cancer does not become an expected stage of life. Cancer should never be an expected stage of life. And when we hear these people talk about exposures and what we know and what we don't know, understand that a lack of information, a lack of insight, a lack of evidence does not translate to safe. Understand that. Also understand your voice is so critical. I was absolutely, nobody heard. I mean, I walked up and down these halls and every building you see around here, hundreds of days, knocking on doors, and nobody knew me. Half the people didn't let me in. And now they say I'm bossy. Even Jan says I'm bossy. So the point is, eventually the shift is made. You are the shift. You are the shift. It's not me or us. You guys are the shift. We need your voice. Keep speaking. Thank you for being here. And thank you to all the students, UVA, my daughter Maeve, friends, family, everybody that's here that helped makes this happen. Thank you very much. Thank you, David Rollins. Thank you, team. So we're going to get the group shot here. We're just all going to pile in front of the screen and see what we can do. Missy's going to want to try to manage you, and that's okay. But we're all going to get right in front of this screen. If we can all step up, don't be shy. No. We're just going to cram them in. It's not going to be great. Just don't worry. They'll fit. Okay, everybody, cram in.